Hi, everybody. Thank you and welcome everybody to the Oxfordshire Joint Health and Overview Scrutiny Committee meeting today. According to the Council's constitution, the positions of Chair and Vice Chair must be elected at the first meeting following the annual Council meeting. So item 1 therefore brings us to the election of Chair for the 2026-2027 Council year. Are there any nominations, please?
I nominate Councillor Jane Hannah to be chair.
Thank you. Is there a seconder?
I'd like to second, please.
Okay. Are there any other nominations for chair? No? Okay. I hereby deem Councillor Jane Hannah, to be the chair of the Oxfordshire Joint Health and Overview Scrutiny Committee for the 2026-2027 Council year. Thank you.
Okay, welcome everybody to this meeting. Thank my colleagues for electing me again as chair. My first duty is for elections for the vice chair. Can I take nominations, please?
I'd like to nominate Louise Upton.
Thank you very much. Any seconders? Are there any other nominations? Okay. Right.
So Councillor Louise Upton is now elected vice chair of the committee.
We proceed to apologies for absence. We've had apologies from Emma Garnett with Councillor Gavin McLaughlin substituting today, so welcome. We haven't had any other apologies for absence, is that right?
We have received one this morning from District Councillor Val Shaw.
Okay. Thank you very much. Oh, she's not well. Okay.
I'm just saying, I have to leave at 1:45 because I've got to chair another meeting.
Yeah, thank you. I mean, just to comment on that, we have four substantive items today where normally we have 3. We've got 5 public speakers, which is fantastic. I will be aiming, because of our external partners, but also for committee members as well, that we finish on time, and possibly even earlier if we can. So I would ask the committee if they bear with me, because that will affect my chairing today, because and if we have outstanding questions, they will be followed up. I'll ask under every item whether they'll accept questions sort of after the item, so that we do have a full scrutiny. But I'll be minded towards, what our provisional recommendations might be in taking the order of questions. So if you could bear with me, that would be brilliant. So we move on to sort of declaration of interests. Can I have declarations, please? Barbara.
So I'm a patient safety partner at Oxford University Hospital Trust and chair of Healthwatch Oxfordshire.
Sylvia.
I'm a patient safety partner at AUH and I'm a member of Healthwatch.
Thank you. And I give my usual declaration as a staff member at SUDEP Action. Right, I'll move on to petitions and public addresses. There are 5. Minutes. Can we look at the minutes of April and Can I just take whether they are a correct record? Thank you. So if we move on to petitions and public address, there are 5 registered speakers. So I'll call first on Councillor Andrew Crawford, who's councillor at Wantage Town Council. And every speaker will be given 3 minutes to speak to the committee. Councillor Crawford, are you here and able to speak? Oh, there you are, thank you. Can you speak on the dentistry services now, please, for 3 minutes? Thank you.
Thank you, Chair, and congratulations on your reappointment. Thank you for returning your attention to dentistry today, and in particular for your last set of recommendations, including securing ICB reinvestment in areas of Oxfordshire that have faced the most severe shortfalls. I'm here on behalf of Wantage Town Council. Through our Health Committee, we conducted a resident survey on dentistry in August last year, with 182 residents taking part. I've just provided the survey to your clerk in my written submission to the Scrutiny Officer and asked that he circulates this, but I wanted to highlight the key findings, if I may. The results show a very clear and pressing need for local NHS dental provision. A significant number of residents simply cannot access affordable care locally. People reported long travel distance, high costs and extremely limited availability. Just over a third of respondents had an NHS dentist, a third were private and a third had no dentist at all. Among families with children, 48% did not have NHS access and 33 families reported having no dentist whatsoever. Most residents could not find an NHS practice accepting new patients, a major issue in an area that has seen one of the fastest growing house zones in the southeast, in fact in the country. Even for those who do have a dentist, nearly half are travelling more than 20 miles for care. Half are not registered locally. And more than half only see a dentist when they have a problem. And while 67% were satisfied or neutral once they'd received care, the barriers to getting that care are stark. Residents told us they want more NHS provision in their locality, with practices accepting new patients in line with population growth, better appointment flexibility and clearer public information on dental health. Many also said they needed affordable private options. It's also notable that most residents knew little about fluoridisation, while most welcomed consultation or were unsure. 70% who had a view did not support it, suggesting that any consultation would require strong public health communication. My own family's experience reflects the wider picture. Like many who had to take extra precautions during the pandemic, we returned to our NHS practice to find out we'd been removed from the list. And my daughter only secured NHS care because my wife registered privately. We welcome the work the ICB has undertaken since the 24 report to address rural inequalities, and we recognise the commitment to making shortfalls in areas such as the Vale. However, we also note that areas outside Oxfordshire have benefited from additional investment beyond this. Rural Oxfordshire still stands out as having the worst access in the region, with only Oxford City meeting the 96% threshold delivery, whilst other districts languish in the late 70s and 80%, and have to give back funding to the centre. The Vale is also the only district experiencing a recent fall in multiple deprivation. And when districts disappear and future government changes, will this inequality even be visible? For Wantage and Grove, we would like to know what proportion of residents have attended a dentist in the last 2 years, or at least to have this data at district level. Our survey showing only a third with an NHS dentist is far below the 46% across the whole of Bob. And going forward, we'll need granular data to ensure that areas of high need are not masked. I also want to acknowledge the commissioning of new practices in Abingdon, Bicester, Cardston, Farringdon and Witney, and the additional activity in Abingdon, Milton and Farringdon. But none of these are in our local neighbourhood. The lived experience in Wantage is one of dental deprivation, a dental desert, as many residents describe it. There appears to be limited recognition of the rapid population growth in areas like ours, with a 22% surge in population in the OX12 postcode alone in the last 10 years. With much larger geography of the Thames Valley and the resources that do not match, transparency on variation in access between neighbourhoods is essential, especially where rural inequalities are escalating, but not measured against population need. So thank you for your continued championing of dentistry, not only as a matter of oral health, but as one of the clearest markers of health inequality, affecting and worsening major long-term conditions and reflecting wider structural barriers to care. Thank you very much.
Thank you.
To declare an interest, I'm the chairman of the Wantage Hospital Health Group, which brought this dentistry.
Yeah, no, we'll. Thank you. So now I'll call for Eddie McDowell, who will speak in relation to continuing healthcare payments in adult social care. Thank you. Please join us.
Thank you. I'm Eddie McDowell, I'm Chief Executive at Oxfordshire Association of Care Providers, which represents the private, independent and voluntary market for all adult social care providers across Oxfordshire in all its diverse forms. Madam Chair, councillors and colleagues, on the 15th of April, a small home care provider delivering continuing healthcare services told us that the newly formed NHS Thames Valley ICB was unable to pay their invoices. To understand whether this was an isolated issue, we contacted providers across Oxfordshire and Buckinghamshire, where we also support providers. What came back was alarming. More than 50 providers immediately reported serious concerns, with debts totalling at least 3 million, some going back years, not just months. We have found out that the total liability is now £44 million, or equivalent to 15% of the annual continuing healthcare budget. Continuing healthcare is entirely NHS funded and delivered by adult social care providers. It is essential to keeping people well at home and to the smooth running of our whole system. Providers told us that they had received no payments, no communication and no explanations. Some had borrowed money to pay staff, others could not meet payroll, rent or HMRC liabilities. One provider has an invoice outstanding for nearly 2 years, another had not been paid for CHC for 3 years. Several have been penalised by HMRC for late payments caused entirely by this failure. This is not a marginal issue. CHC delivery by adult social care providers is critical to the NHS. It adds capacity, prevents hospital admissions and supports personalised care, something Oxfordshire is rightly proud of. We believe this is the most serious local crisis adult social care has faced since the pandemic. But unlike the pandemic, this is not national. It is only happening here in the Thames Valley. Two failures appear to have collided. First, a technical issue in the National Trade Shift platform affecting newly formed ICBs. Secondly, a large backlog of unpaid invoices inherited from Bob ICB and discovered in August 2025, which were not resolved before the new system went live. We have since learned that some CHC clients were not even entered into the system, making payment impossible. This is deeper than a delay. It is a systemic breakdown. ICB finance colleagues are working hard, but Thames Valley ICB knew there was a problem before this committee's April meeting and did not raise it. NHS England has also failed to communicate with providers despite promising an explanation weeks ago. The ICB has set itself a 6-month timeline to clear the backlog. Providers will not survive that long. Some could not pay their staff at the end of May. Recent payments that should have been made on time have also failed, meaning the twin track approach is not working. I ask this committee to hold Thames Valley ICB accountable, request a full explanation of how this situation arose, request urgent reporting on amounts owed, number of providers, number of clients, number of unpaid invoices, and aged creditor data. Established a local steering group, including OACP, to oversee progress and require Thames Valley ICB to deliver monthly updates. And if within your power, request that all CHC payments over 60 days old are paid immediately. A risk to one part of the system is a risk to all. Providers have carried the financial burden to protect vulnerable people. We must act now to prevent avoidable provider failure and ensure this never happens again. Thank you.
Thank you very much. And we'll have an opportunity in the chair's report to update yourself and the committee. Thank
We
you.
also have the CFO of the ICB who's dialed in and will be able to make some comment on that in the chair's update.
Can I call Christy MacDonald, please, who's going to speak in relation to the South Central Ambulance Service, as well as the Oxford University Hospital Quality Account. Thank you, Christy.
Good morning. My name is Christine MacDonald. I last spoke to the committee in September 24 about my epilepsy, the impact of the valproate policy, and the challenges in Oxfordshire epilepsy services. I express my sincere gratitude to the council for allowing me to speak again. I've been following the committee, and it is good to see agenda item 9 maternity refers to a full written update. However, the safety risks identifier across 1% of Oxfordshire's population with epilepsy, their families and the wider system. I am alive today, able to work and care for my family because I have access to the cheap life-saving medication valproate. My knowledge of SUDEP and seizure safety means I can continue to advocate to have this access when others cannot. The 2-signature requirement continues to impact the OUH epilepsy team and waiting times. Patients should be seen within 2 weeks after a seizure, according to NICE guidelines, not 18. Waiting lists are unacceptable and affect wider services. National evidence, CQC and National Confidential Inquiry shows epilepsy is a leading cause of A&E admission and long stays, particularly for people with learning disabilities. Across the South East, deaths are increasing. There have been 6 recent prevention of future death reports, and a coroner is investigating the death of a pregnant woman and her unborn child, requiring a board-level response of their plan for person-centred SUDEP and seizure safety risk communications with epilepsy patients so they can participate in their care. I urge the committee to formally scrutinise progress against the 3 JOSC recommendations accepted in January 25 by Bob ICB, OUH and NHS South East. Commitments were to prioritise the safety of people with epilepsy and wellbeing support for the Oxfordshire epilepsy team. OUH committed to divisional and board level risk escalation co-production using tools like the SUDEP checklist. Both are jointly seeking additional funding for staffing. NHS England South East committed to provide support through guidance, digital initiatives, stakeholder engagement and oversight of regional patient safety work. My MP Charlie Maynard received a response from the ICB CEO recognising the seriousness of concerns and significant work underway to ensure safety and sustainability of service in 25. I note the interim measures of the JOSC include epilepsy nursing team, but this has not grown since 24, which is concerning. With cuts across the NHS South East and ICB, where is the reform work now? Will the planned digital pilot to reduce A&E demand proceed? I contributed to the valproate task and fish group, which brought all stakeholders together. Will this continue its vital work on monitoring harms and mitigation? Scrutiny will be timely. OUH clinicians spoke of new evidence published in 24, which found no link between valproate use in males and risk to unborn children, contradicting the MHRA restrictions, and a large 26 study confirms this. This raises serious questions about ongoing restrictions, while policies affecting women remain deeply concerning, continuing to breach human rights and right to life. The proposed mental health pathway for children is welcome, but seizure safety and mental health must be addressed together. They interlock. Will epilepsy recommendations also be reflected in maternity, learning disability work and OUH patient and public involvement priorities? People with epilepsy remain concerned about delivery of planned mitigations reported to the committee. Co-production and involvement promised to JOSC are now more important than ever and should be a part of OUH Trusted Partner Programme. Scrutiny should also include ambulance and emergency services, primary care, social care and public health, as all are affected and can help. An inquest today begins into the death of an 18-year-old within the ICB area. Your scrutiny and voices matter. Please do not underestimate your importance. To everyone listening and participating in today's meeting, I thank you for your time.
Thank you, Christy. And I'm sure where there's opportunities for all people who speak, that the committee will look to take up questions in sort of relevant sessions. Can I call Dominic Neil Dwyer, who will speak in relation to mental health? Rosanne Edwards, welcome you online now to speak for 3 minutes.
All right. Can you hear me?
Yes.
Great.
Thank
Jolly good.
you.
Thank you very much. Thank you. Welcome to all the new councillors. There's an awful lot for you to get to grips with. It's encouraging and timely to see the Horton General Hospital on HOSC's forthcoming work programme. It's the first review since the OUH began a steady downgrade. It's the first review since the downgrade, which involved training accreditation being removed from maternity, Banbury's successful obstetric unit closed, general surgery centralised, 46 beds closed, and intensive care downgraded, all in a region with unprecedented housing growth. The subsequent pressure on the JR maternity unit has resulted in a horrendous situation of birth trauma, which has been the subject of inspection by the CQC and Baroness Amos's maternity investigation. It may be that no one, except Keep the Horton General and the Banbury midwives, was willing to see that the John Radcliffe would not be able to accommodate 2,000 births from Banburyshire, in addition to its own 5,500, amid a dramatic rise in population. But the decision was taken by managers, all new to the system, working in a system determined to redesign the NHS. The Horton is not just a maternity hospital. It has medical wards beset by delayed discharge and elderly people with mental health needs in the wrong place, a busy A&E and a 24-hour children's ward. Attempts have been made to move 24-hour paediatrics to Oxford, but the staff and community were having none of it. It ran a busy 24-hour general surgery operation until closure was manipulated as an emergency. Manufacturing emergencies is a common way to reconfigure hospital services, and this was a shameful example. In 2016, the community was badly failed by the contrived emergency closure of the obstetric unit. As the population explodes, the preservation and expansion of Horton services are going to become more and more vital. The Horton catchment, including South Northamptonshire and parts of Warwickshire and West Oxfordshire, is due to double by 2040 to 405,000. The JR catchment will grow by the same proportion. The outdated Headington Hospital cannot expand and staff retention is hard. Planning for buildings and staffing to revive the Horton is essential to avoid a catastrophe. HOSC is probably the only body able to get this work started. We have the history, the facts and answers to the denials that will inevitably be made. We'd like to offer HOSC our submission to Baroness Amos's investigation. This is a 40-page comprehensive document with full history and evidence that will provide factual information from which to begin. And hopefully we can be part of this very important work. Thank you.
Thank you, Roseanne. And I think what you said, that can be considered when we get to the workforce planning item at the end of the meeting. So thank you for speaking. Items our officer will introduce.
Thank you. So item 7 on the JHOS co-opted member appointment. So essentially the purpose of this item is for the committee to agree to the appointment of a new co-opted member, a third co-opted member. So the committee is recommended to note the requirement to fill one vacant co-opted post on the committee and the work that's been undertaken to fill this post, and also to agree to Dr. Alan Cohen's appointment as a co-opted member of the JHOS, subject of course to the completion of a register of interest form. There is a brief report in the agenda which outlines the recruitment exercise that was undertaken as part of this. Is everybody happy to welcome Dr. Alan Cohen?
Yes, yes,
I hope so.
yes.
Well,
You're there.
Dr. Allen has been on HOSC previously some years ago as well.
Yeah.
Yeah. Thank you.
And I suppose I was thinking we haven't actually, in terms of other new members of the committee, Councillor Rogers, welcome, because you're a new member of the committee. I think everybody else on the committee is on last year.
Councillor David Hingley as well.
I'm sorry, and Councillor Dingley.
Councillor Hannaby's back.
Child doing A levels, moving elderly parents. Right, okay.
Thank you. We move on to item 8, which is the interim update report on the JHOSC Primary Care Access and Estates Working Group. And essentially, the purpose of this item is to provide the committee with an interim update on the ongoing work and activities that the Primary Care Access and Estates Working Group has undertaken. There are 2 main reports in this item in the agenda pack. One is a cover report, and the other is Annex 1, which is the main interim report of the working group. Now, Annex 1, which is the main interim report, also has its own set of annexes labelled Annexes A to E, all of which are also attached in the agenda papers for this item. Essentially, the committee is recommended to receive and note this working group report found in Annex 1. The other thing that's being requested in the report is for the committee to agree to the appointment of an additional working group member, whilst of course adhering to the constitutional rules around political balance, given that Councillor Gareth Epps is no longer a member of this committee because he is now on cabinet. And finally, for the committee to agree to receive a more finalised version of this report in our September HOSC meeting, which will include a finalised findings and recommendations that will be made as well. As per the council motion on mental health, the committee is also recommended to submit the final findings and recommendations to the attention of the Secretary of State for Health and Social Care as well.
Everybody agree to that? Sorry, you're doing.
No, if everybody's happy with that, the only thing I would suggest is for the members to agree to appoint an additional member of the working group, and for this to happen in this meeting, please.
Can I propose Councillor Rogers, who has been active sort of with the working group, and although it's a Liberal Democrat balance, I think we would welcome Dr. Rogers joining the group. I would, so I would recommend that you second and January second.
So the rules of political balance suggest that if all Lib Dem members of the committee are willing to allow another member of the committee who's not a Lib Dem, in this case District Councillor David Rogers, then we can definitely proceed with that.
Just a correction, I think Dr. Rogers is David's wife rather than him.
Okay. We had an excellent submission from Dr. Rogers to the working group, which was very helpful, and he expressed an interest. So I think we thought that we had a lot of Lib Dems on the working group already, and that this would make it more cross-party. Councillor Hingley.
Thanks. Yes, well, as a Lib Dem member of this committee and somebody who knows Councillor Rogers from Sherwell, I'm very, very happy for him to be nominated to this position. He's got a very long-standing interest in the area.
Brilliant. Okay, so we've got a seconder. Can I take a vote on that? Okay. Against? Yeah, everybody's unanimous. That's lovely.
Thank you.
Thank you very much. So we move on to the response to HOSC recommendations. I'll go through these as fast as I can. We've got recommendations on maternity and on the Oxfordshire Learning Disability Plan there. The committee's also recommended to note the responses that we've had. So in line with our work programme for this year, where we scrutinised children's mental health, we followed up with scrutiny on adult mental health in the April scrutiny meeting, and also that sought to address concerns raised at a full county motion in relation to mental health. So that's the report from that scrutiny. We also have the all age autism recommendations, and we've also got the report to the Director of Public Health annual report, all in the agenda. In relation to the delayed payments concern that has been raised to this committee, and we've had a presentation this morning about it. I wrote a letter in April to the Chief Executive of the Thames Valley ICB and requested an update and for their, by the time of this meeting, really, to have a comment in relation to that. So we're fortunate today. I think, Dan, have we got welcome Richard Chapman, who's the Chief Finance Officer of Thames Valley. It's very good to have you here today. I just wondered if you could sort of update the committee, really, sort of on this issue. That would be really helpful if you could give any verbal update.
Very happy to. Thank you, Chair. If I just set a little bit of background on how the situation arose, if that will be helpful to the committee. So the ICB, as you'll know, is newly formed from Bob ICB and the East Berkshire geography within Frimley. Our normal monthly invoice processing volume is about 7,000 invoices. So we'd expect that figure to be on our books at any given time with a 30-day payment cycle. And just over 50% of that figure relate to all age continuing care, which includes obviously CHC, with the remainder in mental health, care homes, domiciliary care and other areas. Now, in terms of the technical issues that have happened, but all ICBs are required to use a nationally procured financial ledger. And both Bob and Frimley were required to move to a new ledger on the 1st of October 2025. Prior to that move, on the 23rd of September, when all the old ledgers were frozen, we had all age continuing care invoices totaling 2,798 in Bob and around 800 in Frimley, which is about the normal figure for invoices in progress for Bob and just over half what would have been normal for Frimley. And the reason for that is preparatory work had been undertaken in both organisations, because when you change systems, first of all, there is a pause in processing while data is transferred, but also there is the possibility that unforeseen system issues will arise. And that kind of went fairly smoothly, the October the 1st changeover, but it seems that the pickup of invoice clearance in Bob after October the 1st was a little bit slower than that in Frimley, which meant that Bob was in a worse position by April the 1st. Now, April the 1st is important because at that point, both of the old ledgers were closed and a new Thames Valley ledger was implemented. And that changeover was accompanied by some quite material unforeseen issues, none of which were within the ICB's control. And the ICB was not the only one affected nationally, but it was by some distance the worst affected. And the most material issue was that just under 10,000 invoices, which were all partway through processing, so had work done on them, were deleted from the system. And it took more than a week for them to be reinstated as brand new invoices with all of the previous process notes, progress made on them, being made unavailable. So that 10,000 invoices, bearing in mind 7,000 a month is our normal kind of substantive processing capacity, effectively added about 43 days to our processing time. And the scale of that problem didn't really become apparent until the start of May, because clear reporting was unavailable on the new system and there were a range of other unanticipated issues still emerging over that period. So actions we've taken. So first of all, I think the statement said that we have set ourselves an internal target of 6 months to clear the backlog. That is not the case. We are clearing the backlog as rapidly as we possibly can. At that point in time, we had a total invoices on the system about 16,500. We'd expect 7,000 to be on the system at any given time. As of this morning, we are just under 15,000 invoices. So we've cleared about 1,500 since May. We have implemented a new web-based supplier front end. I'll just go back to the complexities and the self-reinforcing problems of the backlog arising in the first place. So because the method by which suppliers chase queries was an email inbox, which is manned by the same staff who process the invoices, the volume of queries simply became overwhelming and effectively diverted staff from processing invoices to answering and logging queries about why the invoices hadn't been processed. And the second point is one of two routes by which suppliers submit invoices, called trade shift, relies on suppliers inputting their own invoice details, and several suppliers, in fact quite a few suppliers, were resubmitting invoices. And there is no automated checking for duplicates within the system. So if, for example, a supplier inputs an invoice with an invoice number 01 and then re-inputs the same number with invoice number 001, the system doesn't automatically pick that up as a duplicate. So that has created, obviously processing is slower because we have to make sure that additional checks are in place to make sure that we don't pay invoices twice. And also it means that the number of invoices in the system is likely to be overstated because a material number of them are duplicates. So first of all,
I'm really sorry to interrupt. It's just that I have to move on really quickly to another item. So I just wondered,
step on a chair
if you could, it would be really helpful if you could provide a written sort of explanation, but also just being clear about when you anticipate this backlog all being cleared for the providers, because clearly it has a massive impact.
It does, and we understand that. So as of this morning, we have reduced the number of invoices by 1,500. Also, as of this week, we've increased the capacity to process invoices for CHC by 60% and mental health by 30%. We have additional capacity coming online. And there is, really importantly, there is a web-based front end available through our website where suppliers with critical liquidity cash flow issues can indicate that that is the case. That goes straight into a database that we can analyze so that we can prioritize payments to those suppliers. And that's a really important message, Chair, but I'm happy to provide a written update.
Yeah. I think it's just really important what your engagement is with the providers and understanding the impact sort of on the providers. That would be so thank you. I think we will move on just because of time.
Thanks a lot, Richard. We appreciate your attendance and your time. Just to clarify, a letter was sent to Nick Broughton in relation to this, and perhaps the response could be, clarification could be provided in the response to the letter.
Absolutely.
Thank you.
Happy to do so.
Thank you.
Thank you. In May, it became apparent that there have been a number of proposed cuts in NHS services. New members may not be aware that the committee is concerned about changes that relate to substantial changes, where the committee is then able to scrutinise. We had gynae services brought to our attention, and also children mental health services at Oxfordshire Health. So with the committee's permission, asked for delegation to myself and the officer to use our normal processes in relation to gynae to write to the ICB and Oxfordshire Health, and in relation to children, in relation to gynae to write to OUH, and in relation to children's mental health to write to the ICB and Oxfordshire Health, seeking clarity on the proposals, the reasoning, and whether there is any impact assessment done, and if so, whether the committee can have sight of that. We also have a letter from Western Valley Parish Council regarding Great Western Park, urgently sort of interested in traction in relation to the provision of that GP estate. As members are aware, this is one of our deep dive case studies as part of the GP working group. So I'd ask the committee to be happy that we would write confirming scrutiny what scrutiny has been done, which has been extensive, and also to share our final report in September with the parish council, and also that we share their letter with the working group going forward so that they can have sight of that as well. The final two items are that in relation to the eye hospital, it's been brought to the committee's attention that members of the public that there may potentially be a tension between the Oxford Eye Hospital and OUH. If the committee is happy, I'd follow through with the scrutiny officer and the chair to write to the trust seeking clarity about this and to bring these concerns to the trust's attention. We did a large piece on scrutiny of this and made recommendations and want to follow through on that. So ask for you to be happy with that. And finally, in regard to Health Watch, committee will actually be aware that we wrote to the Secretary of State in relation to Health Watch, asking for a review, a reconsideration in relation to its initial plans. And we received a letter back rejecting that sort of reconsideration at the time, but they were well aware of the importance of independent patient voice. The committee will want to be aware that the Health and Wellbeing Board Independent Voice Working Group continues to work on exploring and designing a new independent patient voice function post Health Watch abolition, should that proceed. And that is really in response to a recommendation of this committee. But I'd recommend to the committee that we take another step, which is to write to the Secretary of State to urge the government to consider the implications of abolishing the Health Watch function, and that at local area, and that if government intends to proceed with abolition, to enable local flexibility to allow local systems to produce any arrangements that we see fit as a local system to support independent patient voice. So that's the end really of that update.
Just to sort of clarify as well, the Health Wellbeing Board's Patient Voice Working Group has commissioned an organisation called Remind Research, which is undertaking a public engagement exercise to again seek views from members of the public about what they feel about the importance of patient voice and what they think a future patient voice function locally should look like if the government intends to proceed with its plans to abolish Health Watch.
And you'll see in the workforce planning that we've got independent patient voice potentially as a September item. So right, move on then to Oxford University Hospital's quality account. And I do appreciate people will have to leave promptly.
Don't you want us to vote to agree that you want us to approve you to write these letters?
That really quickly, please. Thank you very much.
Not unanimous.
Thank you, Paul. The purpose of this item, so thank you so much for bringing this item to the committee. It's good to have all that detail. We obviously, our duty is to provide a written update, feedback on this, as Health Watch will have done, as an annex to the quality account once it's published. So we want really this item to be one where we agree to provide feedback and finalise the wording of that feedback subsequent and outside this meeting prior to the publication date of the quality account at the end of June 2026. Because we won't be making sort of recommendations sort of within this item. There will be a lot of questions, but I think this will be an item where we will be able to provide that feedback outside. So we'll just take the time to take as many questions as we can. So very pleased to welcome Dr. Ruston Ria, who's the Deputy Chief Medical Officer and Director of Clinical Improvement of OUH, who's been to the committee before, and Olivia Clymer, who's the Director of Strategy and Partnerships, who's been to the committee before as well, and Caroline Armitage, Deputy Head of Clinical Governance, and I'm sure you've been as well. You haven't? Oh, well. Oh, must have seen you somewhere else. So, welcome. So really, have you got something you want to add briefly so that we can go quickly sort of into questions? That would be really helpful.
Thank you, Chair, and thank you, councillors. Really grateful for this opportunity to present our draft quality account. We had some slides, but I think in the interest of time, I'm chairing a meeting at 12 noon at the JR, and I need to leave here at 11:20. So I'd like to move straight to questions, comments. I'm really grateful for your scrutiny for the quality account. Thank you.
Thank you. So I will opening it up to the committee. Bob.
Good morning. Thanks for coming today. My question is around the patient safety incident response framework. You state very clearly in your accounts that the Trust has fully transitioned to PSERF with a shift towards thematic system-based learning reviews. Can you provide quantified evidence of how this shift has translated into measurable improvements in patient safety outcomes rather than in process change alone? And how does the Trust follow up to ensure that these changes have been made and they've really made a difference?
Thank you, Barbara, and thank you for that question. So as you know, as patient safety partner, there have been 4 things that essentially we've done to try and embed PSERF, and those are aligned with the 4 main pillars within PSERF. One of the things I'd point to is the quality of our investigations, and so we've used the HSSIB tool to independently look at the quality of investigations prior to PSERF and since PSERF, and we've shown significant improvement across all 9 domains. So that enables us to give us confidence that not only are we investigating our incidents more robustly, but actually we're producing actions that are more likely to lead to a safer environment. I think the other key thing that you've raised, which is really important, is not just the recommendations, not just the delivery of the actions, but whether or not the delivery of the actions has made a difference to the risk of that incident happening in the future. And so one of the things that we've done is to introduce on our weekly safety, learning and improvement conversation, a component of the reflections to come back to the committee 3-4 months after the publication of the incident report to demonstrate the evidence that the action that's been taken has not just been implemented, but has reduced through audit, through whatever means is available, the risk of those incidents happening. And I'm happy to provide outside of this meeting some examples of where that's been achieved.
You just I noticed in the report that you're in very much in the same area on mortality as other trusts. But obviously there's always learnings from deaths, aren't there, sort of in a trust. And I just wondered, I could see the learning within the report, but I couldn't find one reference to one particular report, and it may be because of the wording, but it related to a coronial report on the 11th of August 2025 around a unnecessary operation that hadn't been investigated internally, and there were communication issues in relation to other hospitals and the OUH. So I was really going to ask, do you know if that report is in there? But also just, is it part of that work on the safety framework that you're taking forward? And a follow-up about that, for the bereaved families that are at the centre of prevention of death reports, do you systematically tell them what you're doing to progress the actions? And indeed, is there ever any offer of co-production so that the legacy of the person that died can actually be a future legacy to safety?
Yeah, thank you, Councillor. That's a really important point of that combination of deaths and investigations. So just to give you context, our HSMR is below expected, although our shimmy is as expected. And I think that's both within a rolling 12-month period with HSMR. We've also had a reduction over the last couple of years in the number of prevention of future deaths notices given to OUH. And I think that's due to a number of factors, but it is increasingly going back to Barbara's point around the quality of our investigations, not just the investigations, but the evidence that we can then present to the coroner of the learning and the actions that have taken place from that learning and the evidence of the effectiveness of those actions. I think there has been a significant amount through the PSAR framework of learning of how to do that and how to do that better. I'll need to go back to have a look at that specific investigation back in August 2025. In terms of co-production, when we see that there is evidence of learning within a death, then we instigate a learning response. And as part of that learning response, we draw in the understanding, the concerns, often the really important insights that relatives will give us as to what we can do better, either in terms of our processes or in terms of our communication. So that is part of the PSARF process, and it's entwined with our mortality reviews. So as soon as we see something that's learning, we engage with the families and bring that in.
Thanks. Good morning. Thanks very much for letting us have a look at this report. You do confirm in it that some of the priorities have had to be carried forward because they weren't fully delivered. Could you just let us know what you think the main reasons for that not happening? Is it workforce? Is it funding? And have these factors now changed so that these rollover priorities don't just keep rolling over with all the sort of continued risk to patient safety that would entail?
Yeah, thank you, Councillor Upton. That's very perceptive. So if we take a couple of those quality priorities, one I think was around deteriorating patients. So the SEND programme that's been developed in Oxford. I think the further we got into that quality priority, the more we realised that the platform was probably not as robust as we had hoped going to the future. And so we've actually procured a new machine and a new platform for recording the observations of deteriorating patients. So what we've done is we've taken that, we then reprogrammed it not to deal with the individual platform, but to talk about a much broader concept, which is how do we make sure that the vital signs are recorded appropriately, how do we make sure they're escalated appropriately, and how do we make sure they're responded to appropriately. So that has gone into a bigger and probably more comprehensive quality priority this coming year. The pharmacy one, the medicines reconciliation one, I think is a broader piece, and I think the more we got into the medicines reconciliation, particularly around admissions and discharge, the more we recognise this is to do with interoperability between primary care, community care and hospital care. The thing about quality priorities is they're meant to be delivered within year, and I think that was going to be too ambitious to do that within year. So we've put that into a much broader digital program. So looking at our electronic patient record and how we can draw in medicines that are already well recognised within primary care, so that we can do that in a more sort of automated and robust way. So I guess the short answer to your question is yes, we will carry them on, but in different guises. And I think the answer to your second part was what we've done this year, which is different to previous years, is that upfront we've looked at what are the resources that are needed to deliver these quality priorities. It might be digital resources, it might be financial resources, it might be operational resources. We've quantified those and we're having regular meetings with our finance and digital colleagues to make sure that the quality priorities are resourced in order to make the best possible chance of delivering this year.
Could I just follow up, just in relation to the digital driver? You've actually got some great efficiencies here with the glucose report and also the ambient voice work. There are other so there could be quite a lot of questions around that, but I just wondered, in relation to your digital driver, are the safety champions involved, and is co-production at the heart of that digital drive?
Yeah, that's really interesting. So let's talk ambient voice technology, and that's very much been driven by a combination of clinical services requesting a much more 21st century way of dictation. So ambient voice technology, you do a consultation with a patient, the ambient voice technology is sitting in the background, capturing that consultation and then writing the letter essentially, and then that's shared with the patient and sent to the patient. And it provides a much more holistic experience both for the clinician and for the patient. The evidence for that will be gathered both from feedback from patients and from clinicians to make sure that we choose the right provider, but also that we deliver this in the right context. And it might be fine in an individual room with two people talking to each other, but on a busy ward round with multiple people around and curtains around, that may be more difficult. And so we'll need to make sure that the patient, the relatives and the clinicians are all satisfied with the quality of that production.
Thank you. I think,
Thank you. I've got a couple of questions, but just to pick up on something that Jane has mentioned a couple of times and you've responded to. What do you mean by co-production?
I think it varies in the context.
Well, what's your definition?
I don't have an offhand definition, but my if I look at patient safety, I would start with the understanding of what is the issues that the patients and the relatives want to bring to the table. What are the key things that they feel need answering, but also what are the key things that they will be able to suggest and give as suggestions of improvement. So that would be the initial basis. I don't think it's a single thing. I think it's an ongoing conversation. And so when I've met with families, I see this as being a process rather than a one-off. And as they continue to reflect, it may be that they've had further experiences, maybe they've had further thoughts and understandings that they want to feed back into our processes. So for me, it's an active verb rather than a single one-off process. Did you want to have it?
I think you raise a really helpful point there, Councillor. I think we're keen to keep growing our confidence, expertise and examples of co-production, co-design, getting that patient voice right into the challenge that we're trying to address across pathways, but also as we develop the quality account itself, Caroline and colleagues, host that open meeting where we engage with the public and take that on board. So I think it's appropriate to the scale and challenge that we try and address, but very minded that that has to be at the heart of our work. Thank you.
I suppose the other thing just to add to that is the new patient engagement and experience plan that Aletha Bicknell, our Director of Patient Experience, is drawing up and is part of our new quality priorities this year.
So can I ask the other two bits?
Follow up?
So just to follow up on that, what you're talking about is engagement rather than co-production. So maybe this is part of the problem. We constantly ask about co-production and we constantly talk about co-production, but nobody is actually talking about one single thing. It's constantly something different. And you hear people use the word co-design, which is different to co-production. If you look at TLAP's website, you'll find that there is a very, very clear definition there, and I suggest the OUH look at that. Looking at page 206, the penultimate bullet point about non-Hodgkin lymphoma. You're talking there about access to clinical nurse specialists was recorded in more than 95% of patients, well above the national benchmarks. How long does it take for a patient to have specific contact with a nurse specialist?
(206), is that what you're saying?
I'm looking, I think it's page 7245 might be something you can refer to.
Sorry, but
your thing's been reproduced in our paper.
Right.
So I
You'll
think
have to give me
it's
some
page
context.
7 of 245.
The 245.
No, page 7 of 245.
Right.
Slide
Beg
7.
pardon.
Okay.
You're going to have to, so I'm on page 7. Just repeat your question. Sorry, Councillor. Thank you.
Yeah, I just wanted to mention that there's access to a clinical nurse specialist was recorded by more than 95% of patients, well above the national benchmark. My question was, how quick is that contact with the nurse specialist?
I don't have those figures offhand, but I will get them for you. Thank you.
My personal experience, being a pancreatic cancer sufferer at the moment and being treated by the trust, is that it takes days to get a response back from a clinical specialist. And you'll find that when you ring, if you go through the triage system, there's even greater delays.
Yeah.
So, you know, I think it's great that you are above the national benchmarks, but it's still not good enough, really, because people do need answers. The illest of people need answers from a clinical specialist. And my experience is that doesn't happen.
Yeah, I'm really sorry to hear about your personal experience. I think that's really sad, and my condolences on your diagnosis, but I'm very happy to take that up with the service and either individually with you outside of this meeting if that's an ongoing concern. I'm really sorry about that, and I wish you well.
Thank you. And just picking up on that co-production point, this committee, we get the reports in from different providers and we're working with different system partners. So we actually find we have different meanings to words that are coming from the different silos, really. And I just wonder whether there's something there in terms of whole system working, you know, particularly with the move to neighbourhood. I mean, maybe it's, you know, neighbourhood is a good place to start, actually, you know, in terms of where everybody's having to talk. I appreciate the investment isn't there, but actually just getting that vision of like, well, what do we mean when we say co-production? But I also found in other parts of the report, there were things like red flag complaints, which weren't actually defined, but then that's different from what Oxfordshire Health says in terms of how they talk about complaints. So there's a whole information accessibility issue here, which can really help the public to understand, which isn't particularly up OUH. It's actually that there's a system issue about, you know, well, that example, what does it mean, co-production? And I'm just wondering, with your trusted partner framework, which brings in those 10 organisations, you know, whether that is actually a potential vehicle for OUH in relation to getting some common understanding.
Very happy to respond to that, Councillor. I think that's an excellent observation and all too true, having worked in local authority and other sectors, the infinite variety of definitions around co-design, co-production and stuff. And I think that's a good challenge to put to us, and certainly as with system working and as we've expanded to Thames Valley and noting with neighbourhoods, it's not just about the NHS, it's also about our colleagues in local authority and the VCS and community members, so that we do get that a shared understanding in this context of how we work and what that means to us for this project or this programme. So certainly happy to explore that and provide a response. Thank you.
Thank you. Barbara.
I've got a question about respect and version control. I see in the report that you're saying that the ICB have got a platform, but you're not able to edit that platform at the moment. There've been examples of respect issues that have come through where family have not known about what's on respect forms. Different respect forms are at home to those that are in the hospital. I mean, how can you and our colleagues from the ICB ensure, give confidence to patients that the most up-to-date respect forms are being used, and that when patients change their minds, that is taken into consideration?
Yeah, that's a really good point. And this goes to the heart of a single digital record, a transferable digital record. And we know that that's not in existence at the moment, unfortunately, both locally, but also nationally. But there are some plans towards that. So as we go through what I was referring to earlier in our digital refresh and thinking about how our electronic health record intertwines with not just primary care, but as a tertiary centre, how that intertwines with places outside of Oxfordshire. We need to be thinking about access from patients as well as from across the whole health community. So this particular point has been raised with our Chief Digital Information Officer, and he's fully aware of that and thinking about how to keep the very best of what we've got as our own respect form, because it triggers lots of other processes within our trust. It triggers things like a treatment escalation plan, it triggers conversations, and so we've built quite an infrastructure around our respect form, but also have the ability to share it with the patient, share it with primary care colleagues, and to ensure that they can update it and they can send it back to us in a more, as you say, in the most updated version. I haven't got a solution to that yet, but that is definitely very much on our Chief Digital Information Officer's to-do list.
Yeah, and I think part of it is it becomes a central part of the care planning, right? So the more that we use these things, like Rustam's described, the better we're going to be. So that is a fundamental part of the care planning for the system and how we coordinate care. I think, Barbara, you said about as we look at neighbourhood health and care services, coordinating for complex people, coordinating for people with palliative and end-of-life care needs. That's going to be the fundamental form that we use to do that. So the more that we use these things, the better we're going to be. And like we say, then the interoperability and the digital interface is going to help even further.
Have you got somebody working at your end to ensure that?
Yeah, we've got a palliative end-of-life care team that lead that, and the complex care team.
Yeah, so you're going to change the digital platform so that other health professionals can update the respect record from wherever the patient happens to be at that time.
The intention is to have fully interoperable shared care records.
Mark?
Looking at the health inequalities and learning disability provision, page 86 of the report, the quality account outlines the rollout of reasonable adjustment flag where the EPI has been delayed. So what is the revised delivery timeline, and what interim measures ensure that patients with learning disabilities continue to receive the appropriate adjustments? And just a quick one to add to that, the trust report delivery of Oliver McGowan's training, what evidence exists that the training has resulted in improved staff and confidence behavioural change in the clinical practice?
Yeah, thank you, Councillor. It's really, really important. And one of the reasons we brought it in last year was just to have increased focus on vulnerable people and people with learning disabilities. Not that we had particular signals, safety signals, mortality signals, but we recognised there was lots of work going on around the trust, and we wanted to bring it A, to a greater visibility, and B, a more coherence around that, and give some resources to the team who are leading that. So this work's been taken up by one of the divisional nurses. So they've now got a monthly learning disabilities group that's meeting regularly to progress this. There is now a number of services that have a list of their patients who've got learning disabilities, and they prioritise those and ensure that when they come to an operation, an investigation, a diagnostic procedure, the reasonable adjustments have already been thought about prior to them coming to the operation. So that might be to do with different types of sedation, it might be to different types of access into the service, explanations, making sure the patient information leaflets are appropriately appropriate for those patients, but also making sure that they've got their trusted people with them, and so their relatives or those who can come with them and keep them well. So it's an ongoing process, but we wanted to raise it last year to try and consolidate the work and to try and highlight it as being one of a work that we think is incredibly important. Yeah, I'm not sure that answers all your question, but was anything else? Are you sure? Yeah. That would be great. We're really, of course, yeah, if you contact us.
I think it's probably worth, just by chance, it's worth adding that the group that meets regularly, and I think, like we've said, that the team in AUH and across our system are really outstanding, but the group that meets regularly is from OUH, Oxford Health, the ICB, and we meet with My Life, My Choice as well. So just going back to that co-production stuff, a lot of the work that we're talking about here and a lot of work that the divisional nurse leads has been instigated by the group at My Life, My Choice. So just from the point of view of how that's working.
And interestingly, My Life, My Choice came and spoke to this committee several times, and actually they spoke in relation to the item that Christy spoke about this morning in relation to epilepsy. Epilepsy is a very wide spectrum, but for people with learning disability, 1 in 5 have got epilepsy. And the points that Christy made don't cover, sorry, the points that she made, the Oliver McGowan training doesn't actually relate to. So Oliver McGowan is an important step, but for the 1 in 5, it doesn't tackle the gap that Christy was identifying there this morning, but also that who was it? My Life, My Choice came and spoke to the sort of committee about that gap too. So I suppose I was just going to ask as a follow-up, sort of whether in relation to Christie's presentation this morning, whether that's something that you'd be able to sort of take on board and consider.
Yes, and I think there will be certain specialties where learning disabilities are much more to the fore than other specialties. And I think I totally get your point in terms of neurological diseases. You can think of traumatic brain injury, you can think of post-stroke, where epilepsy, learning disabilities are really prevalent. So I think our learning disabilities team, together with the ICB, will be focusing on those areas as a priority to try and make sure that we have reasonable adjustment, so that when they come in for their operations, they come into their investigations, that we've done as much as we can. But also when they come in as an emergency, that reasonable adjustment flag is there, and we have a sort of coherent understanding across the trust as to what we need in order to deliver the best care for those patients.
And there's a lot of work being done on reasonable adjustment, and actually that is where, again, I think co-production is really, really important. So it comes back to that earlier conversation sort of about co-production, which Christy's talked about. Thank you. I'm just going to see if there's anybody else first, because we're going to have to finish in 5 minutes. That's got a question. I'll come back to you, Paul, at this time. Elizabeth.
Thank you. It's quite an extensive read, very impressive. I sort of reading through, I wondered how anyone has any time to treat the patient, really. And there's an excellent glossary at the end. Is co-production too difficult to put into that glossary, perhaps?
No, we will put that in. Thank you.
What I was really going to ask about was the page 101 to 103 or something like that. Explanation of national audit where case ascertainment is below 100%. I presume by case ascertainment doesn't mean you haven't diagnosed the patient, but perhaps whether they really fit into the audit. With this, a lot of them, it says, and we didn't take part, or that kind of thing. Or down here, the perioperative quality improvement program, they seem to suggest that you don't require every case. So it sort of seemed rather confusing in that respect. But I hope that when one tries to take part in the national audit, even if you don't fulfill what they require, do you pay attention to what the results come out?
Oh,
and my final point is a slightly personal one, but it's something I feel quite strongly about. I was foolish enough to do something, and you would tell an 8-year-old not to do, when I was visiting a National Trust place in Buckinghamshire. Buckinghamshire is the important bit. Last July, and it ended up with a total hip replacement at Stoke Mandeville. I was there for something over 2 weeks, largely it seemed, because you need some aftercare sort of equipment in the home. And they kept on saying that Oxford Health Services, whatever, weren't responding. I don't know whether the fault was with Buckinghamshire or Oxfordshire, but the problem was getting the equipment. And I mean, I was threatening to go home by bus because of the delay. And I just wonder, when you're looking at discharges, do you ever look at trying to speed up the difficulty if people live in a different area? Thank you.
Oh, thank you, Councillor. 2 really good points. So the first point is, yes, we do. We absolutely look at all of our national audits. And in fact, the meeting I'm chairing at 12 o'clock is to look at our national audits. So whether we participate in them a little bit, a lot, fully. We absolutely look at all of them, and we look at the outcomes. So what are we doing, and how can we improve our participation each year? I'm really sorry about your experience, but one of the things that we are continuing to focus on is discharges, getting a really good quality discharge, so that the alignment of the patients, the clinicians, and the people who are receiving the patient, and that might be care agencies, it might be relatives, it might be primary care, making sure everybody is on the same page as to what's needed, and then unblocking those blockers as you've just described in terms of equipment in particular.
Ian?
Yeah, just to come in on that point, we have a system-funded transfer of care manager and team, and they look at all referrals for discharges that are coming into Oxfordshire, irrespective of where they're coming from. So when somebody is identified in Stoke Mandeville or the Royal Berks, for instance, it goes into that team just as surely as if it was in the, so the person was in the Horton or the JR. Sorry, when did this happen? Last July. You probably, if that was an equipment issue, we were in the middle of the collapse of our equipment provider. So apologies to you, but that was a very difficult time for the system. So in normal course of things, as Ruston was saying, the planning, the discharge, and it is one of those things, the coordinating of equipment, care, family needs, and so on. But that is what our team is trying to do. And those discharges would be coming into the council to the Home First team to help people get out.
I'm going to take two more questions. All right, 3, but can they be really precise? So Jenny first, and then Alan, and then Sylvia, and then we'll finish. But then we're going to put. So Jenny, I think, was first, weren't you? Yeah.
Well, it's something actually that is very much for the county council in the Oxfordshire way. So it's about the discharge. The Trust reports ongoing implementation changes to the discharge safety checklist, including delayed rollout and variable compliance. What is the current compliance rate across sites and specialists? And by when will 100% compliance be achieved? Multiple discharge interventions are described in the quality account. Which specific interventions have demonstrably reduced lengths of stay or delayed discharge, and what metrics are being used to track, and how is the Trust ensuring that discharge processes are not only efficient but also safe, particularly in relation to medication changes and patients' understanding? And I'm asking that one because I was very much involved with the Oxfordshire Way starting that, and medications and discharge and people there for a very long time was how we worked together. That's quite concerning that I've got that in front of me again. So if you could reassure committee.
I think that's an ongoing piece of work, Councillor. And I think I'd say 3 things to that. One is that it continues to be a quality priority. So how do we ensure good discharges? One of the key things we've done is board rounds, so instigating a consistent approach to looking at all our patients every day, trying to understand who is going to go home today, who's going to go home in the next few days, have we got their medication up to date, and can we get their medication to them before they go home, rather than at the time of when they're going home. Make sure it's not rushed, make sure it's not a delayed discharge, make sure that it doesn't go to them after they get discharged. And then the crucial bit there is communicating that in a digital way, both to the primary care physician or community care who are looking after them, but also giving them a copy of that so that they have a really understanding. So this is a combination of culture, and this is where the board rounds has made a significant difference in reducing those delays and reducing the length of stay of our patients, because we've been able to get that medication to them sooner. It's a digital process as well to make sure that we've got interoperability, just as my colleague was talking about. But it's also giving agency back to our patients to say, I need to know what medication I'm on. I need to understand why I'm on this medication, and I need to know what the changes have been to the medication before they go home. And those are the things that we've been working on, which I think will make the biggest difference.
I'm going to take, could Alan and then David Rogers and then Sylvia ask your questions in turn, and then if we could then have an answer, and I understand if you have to leave, then I know just leave. But if we could just have those last few questions, that would be great, and then we'll. Paul, I know I'm sorry, I'm going to have to draw the line somewhere. I'm sorry, but you. Yes, but you can do it afterwards in writing, okay? So, because I've just got to get through the business, and we're going to get the questions through, okay? So, yeah, Alan.
Thank you. Top of page 188 of your report. Violence against staff has gone up over the last 3 years.
Yeah.
What can HOSC do or anybody else do to do something about it?
Thank you. It's a real concern of ours. We have regular reporting. We encourage staff to report anything that is abusive, violent, racial, sexual. We call the police in regularly, but that is not a deterrent, and it continues to escalate. It continues to affect staff, their willingness to work, their retention. I think I'm just grateful for HOSC to acknowledge it. However you want to support would be grateful. And I think that it's a system-wide approach, and I don't think this is just OUH. And I think it might be useful to think as a system, how can HOSC draw together some of the key agencies, I'm thinking police, but also safeguarding. And unfortunately, a lot of our patients do suffer from mental health problems, or they suffer from addiction. And so drawing those services in would be really helpful as well to try and do a coordinated approach across the whole healthcare economy. Thank you.
I know that there's been a lot of work done with maternity, but there's still some areas that require improvement.
Yeah.
How do you plan to address that, and what sort of timeline do you have?
So thank you. And I think there's two things I'd like to say about maternity. I'm sure HOSC would join me in acknowledging all the work that has been done in maternity, which has resulted in the CQC rating our maternity services both at the Horton and at the JR as being good last week. And so that's an improvement from requires improvement, and it results in the Horton overall as being rated by the CQC as good. The ongoing work in maternity, I think, is twofold. One is around outcomes, and the new Embrace report has come out and showing some really good outcomes from our perinatal mortality. But I think crucially, it's about patient experience, and that's where we see the ongoing work with Quality Priority this year around embedding with our patients, trying to understand what it is they're experiencing at the time and what we can do about their experience at the time and not in retrospect. And so it's on the day saying, how are things going? What can we do to improve your experience? And that for me is the crucial thing this coming year. Thank you.
Thank you. So I'm going to draw that to a close and just say thank you hugely for answering all our questions. We did have an infection control question, and it was really good to see that you're first in the all the big hospitals for infection control, and long may that continue.
We also have some follow-up questions on the myeloma choice from Councillor Sargent, which I'll send to you.
Please do. Yeah.
Okay, that's lovely.
Thank you, councillors. Thank you, Chair.
Thank you. Right, we move on to the dentistry services item. So we have Julie Dandridge. Welcome, Julie. Come up. We've got Dan, and we've got Nilesh Patel from the local dental network as well, which I think is Nilesh joining us online? Just thinking. Oh no. Okay, while you're settled, I'll just introduce the item. So the purpose of the item is to receive an update on the current state of dentistry. The HOSC last received an update in 2024, and we issued recommendations to the ICB on dentistry. The committee also wrote to the Secretary of State at the time to share some of our findings on dentistry, and also to ask for support for a local public consultation around fluoridation of Oxfordshire's water supply. The committee was previously concerned about access to NHS dentistry, as well as the emergence of dentistry deserts. And we obviously heard Councillor Crawford this morning speak about his particular neighbourhood, and it would be good to receive some reassurance on these developments. Julie, did you want to say anything by way of introduction before we go into questions? How would you like to?
Yes, that would be good. Thank you. Thank you, Chair. Thank you for the invite to come and talk to you about dentistry. I think I've sat at this table with other hats on, including general practice, primary care and estates. But today I'm here as the Associate Director of Pharmacy, Optometry and Dentistry, and are following up on the report which we presented last year by my colleague Hugh O'Keefe, who has now retired. So I'm presenting the report for you today. Since we last came to HOSC, we've seen 4 new dental practices open in Oxfordshire, in Chipping Norton, Milton, Witney and Farringdon, and we have now replaced more activity than we have lost through contract handbacks, which happened after that difficult time following the pandemic. There's been a lot of focus on access to urgent dental appointments. The government manifesto was to deliver 700,000 more appointments. And in Oxfordshire, we commissioned 19 practices last year to deliver nearly 6,500 extra appointments. It was quite a difficult target to achieve, but actually across Bob we did relatively well and best in the southeast region. We continue to have our flexible commissioning scheme last year, which gives access to our most vulnerable people, most vulnerable patients, and had approximately 30,000 attendances to that flexible commissioning scheme. The other component that we've interacted with last year was to try and promote children's oral health promotion. We engaged our new practices in having a component of oral health promotion in there, and it really only kicked off in December, but for the first quarter of the calendar year, approximately reaching out to 1,400 children in nursery and primary schools, talking about the importance of going to dentists, teeth hygiene, etc. I think we will continue to see that scheme grow. Going forward in the report, we also talk about the new dental contract, which is the first big reform that we've had on that, which now embeds urgent dental appointments into the contract. So all dental practices have to provide some urgent and non-scheduled appointments. It also strengthens the use of fluoride varnish, and also some of the quality initiatives. We've managed to maintain our vulnerable patient scheme, although we have narrowed it slightly, given that the new contract should open up access better anyway with the provision. I included in the report just a follow-up of the recommendations from the last, but I think probably, Chair, it's probably right to take questions now. Thank you.
Thank you, Julie. And we do know, obviously, that the responses that you made and the work that's been done since the last committee. Just before we launch into all the questions, the first question on our last session was actually to get the committee the view of in terms of what was the single most effective measure in terms of the evidence now for children's dental health and to minimise children ending up in A&E, in emergency services, because of the state of their teeth. And at that meeting, there was a unanimous view that the single most effective measure was fluoridation. Certainly the view of my dentist. And so I just wondered, I mean, obviously we heard the complexity of that, and we actually heard Councillor Crawford talk about the public not being sure, not really having much knowledge about it at all. And, you know, so, but this is about, the recommendation last time was about a consultation. It wasn't about doing it, you know, so it was just, are we still in the same state of evidence? You know, is it still the case today that that would be the single most effective public health measure for children's teeth?
I'm happy to comment on that. I think it's quite easy, yes. There's no question about it. But the implementation of that is often quite complex, as you would know. And if you look at the example in Northeast, it's taken decades to get to that stage. I think it's a little bit easier now. I think we should pursue that. But the approach is about taking proportional actions at every level. So I think there's something about actually pursuing that across a long term, but actually also doing the other things. That includes the public health interventions around supervised toothbrushing, interventions around having proper dental care if they were to have problems with their teeth, particularly for children and young people, and providing accessible care. So it's about taking an action across that whole proportion, from fluoridation to providing access at the right time in the right place.
Yeah, and I think we'll get a question around that broader sort of approach, I'm sure. So I just wanted that bit of yes, no, and it's brilliant. Yes, thank you. So open up to questions. I think Councillor Hannaby.
Thank you very much, and thank you for Councillor Crawford coming to speak to us today. Section 2 of the report states that 46.5% of the population has seen a dentist in the previous 2 years as of March 2026, compared with 51.29% pre-pandemic. What is the ICB's trajectory and timescale for returning to the pre-pandemic access levels, and what specific interventions are expected to close the remaining 5% point gap? And how does this trajectory differ from Oxfordshire's localities?
Thank you, Councillor, for the question. I think so. Where are we going with this? So we have made great inroads into trying to improve access, and I'm confident that actually the new contract that comes in actually encourages our dental practitioners to open up to new patients. I think I've been around this table before talking about dental practices that are talking about closing their lists. You know, practices closed to new practice, new patients. Actually, with the advent of having to have 8.2% of their contract now as urgent appointments, there will be the access. I do, however, think we need to potentially do a bit of work on re-educating the public, and one of the bits in the new contract is for our dental practitioners to review their recall. So I remember, so I'm sure many of us remember going to the dentist and saying, come back in 6 months. Everybody just needs to come back in 6 months. Well, that's not necessarily the nice guidance anymore. And the recall has to be person specific. So some can go longer, some can go shorter. I think the other bit that I think is really important, which we've touched on already, is that children's oral health promotion, because actually I think we need to get our children used to coming to the dentist at an early stage, so that actually becomes a regular part of them looking after their health care. I don't think it's going to be easy to get to get back to pre-pandemic, because I think there are a lot of changes that have happened, and also patients' expectation. I also think the number of private dental services are growing, and people are choosing to access that. But I'm hopeful that the new dental contract, which does provide better access, should see that increase.
Louise.
Thank you. Yeah, I'm just looking at the chart number 1 in section 2 of your report, which looks at the number of people who've accessed NHS dental services in the previous 2 years. That, I guess, doesn't take into account, though, the people who couldn't get registered with an NHS dentist and didn't attend anywhere at all. So I'm just wondering, do you have a metric that captures that?
We have no way of capturing who's tried to get a dental appointment and who hasn't, other than through potentially emergency and A&E attendance, or GP practice attendance. I think what we used to get at the ICB, the CCG before that, was lots of complaints about dental access and dental access lines, and also working with Health Watch as well. I think we've all seen that actually the number of complaints, queries coming back has dropped right down. So we might get 1 or 2 a year, whereas we used to probably get 10 a week.
Thanks, that is interesting to hear, because it was a major thing that Health Watch always bring to us.
Thanks, Julie. Just to follow up on that question, I'm just wondering if there's any way to track that through people who've contacted 111 who claim that they didn't manage to get a routine dentist appointment, and who then go for an emergency appointment.
So we do have 111 dental people who contact 111 through for dental, but in the main they have been referred on to some of our dental services as described here, either the flexible commissioning scheme or the urgent ones that we've seen. We can't track the 111 calls that then end up in ED as a result of not being able to access ED, which I think is what we would like to see here.
Health Watch. Veronica, do you want to come in?
Yeah, I'd just like to reiterate what you're saying. Like, we used to have 7 calls a day about dentistry, but that has really fallen off. It was our top thing. So that's great. I was just looking at the flexible commissioning. I'm really pleased to see that you've managed to retain some element of that, but I just wondered how that would be monitored, and so that it doesn't widen these health inequalities, because I think we heard some people aren't going to dentists at all. They're bypassing the whole thing now. And the other thing just to raise is really pleased to see that there's a dental NHS coming to Farringdon. In our rural outreach, we heard quite a lot about that when we were in Farringdon area, the lack of dentists and people having to travel long distances. So that's a really positive.
Mark?
Just a quick one. I want to ask what work's been done with armed forces families, because obviously relocation every 2 to 3 years, and generally what it is, I mean, there's a struggle sort of nationally with NHS dentists, but usually they're at the back of the queue. So I want to know what work's been done with armed forces families, please.
Yes, yeah, thank you. We haven't really had big issues with the armed forces trying to access our local dental services, but one of the things that we are doing with our access for vulnerable patients scheme is reviewing those cohorts. So actually, if there are cohorts that come along, then we can add them. So, for example, I heard your earlier discussions around that patients with learning disabilities. Well, we added those to the cohort so that they could be seen sooner and earlier as part of our vulnerable access scheme. There is hope, and I think the national initiative to make urgent and unscheduled dental appointments more readily available should make access even better. But it's certainly something that we are monitoring in terms of where dental practices are in terms of achieving those units of dental activity, where there are gaps in provision.
Barbara?
Before we move on, sorry, Julie, would you mind answering Veronica's question? Because we sort of moved across before you got a chance to say anything.
Thank you. So I think yes, yeah. The practices who are currently delivering the new scheme are very similar to the practices that are delivering the old scheme, and we meet with them very regularly on a monthly basis to understand what sort of patients are coming through, what sort of patients they might not be hearing. I suspect that actually at the start of the financial year, access isn't going to be a problem. It may be a problem further on as we progress through the year and practices have achieved their urgent dental appointment sort of 8.2%. And what we are looking to do is to review the number and provision, and potentially where there's under provision, move it to practices that are over providing, so that actually we do get a better spreadsheet. But it's something that we really want to make sure that we are not increasing that inequalities. So if there are patient groups or things, we are open to adding them.
Just in relation to that sort of inequalities of access theme, and what evidence do you hold in relation to population need and rates of recovery for adults and children by rurality or by district? And what will happen in relation to the reforms going forward with local government when the districts are abolished, in terms of where will the granularity of data be? Will it be at neighbourhood level that in the future, people will be able to ask at Scrutiny to enable to have visibility of population need and how that need is being met?
Thank you, Chair. As you can see at the moment, we sort of map it on local authority, on district level, district and city level. But we are able to, it sounds wrong, cut our dentists in any sort of permutation possible. And I think dental provision at neighbourhood level will be a really important part of the local offer at near a patient's home. And that is something that we will look at, and really it's really good to see some of our dentists already engaging with our GPs and our other colleagues on that footprint.
Yeah, can easily see the inequalities in under delivery of the dental activity, but then it's that other stuff about where the population need is, isn't it? And then and how many people are actually accessing dentists. But that's helpful. Alan?
Thank you. I was going to ask about health needs, vulnerable groups, but I think that you've been pushed quite a lot about that. But I would like to suggest that you include, for example, people in care homes and people in prison and long-term mental health care who have enormous difficulty in accessing care. And my other question was really to Ansaf, if you could give us a 2-minute discourse on the problems with fluoridation and why there are barriers to fluoridation. 3 minutes. On the barriers to fluoridation, because clearly you've said already it is the most effective intervention, but there is clearly a problem with fluoridation, and a lot of us would quite appreciate to understand what those barriers are and what can be done to try and relieve it, because if there's an effective intervention, why shouldn't we be implementing it?
Yeah, I mean, it's quite clear, the evidence base. So, David, if you look at the levels of tooth decay that we had before fluoridation across the country and across Europe, for that matter, it was quite significant. We saw a big drop in the level of tooth decays and related issues around that, dropping quite significantly. But I think in this country we have had some real concerns, if I'm being completely honest, around putting things into our supply of water. And I know there is if you go to very high levels of fluoridation, there could be potential impacts. But we're not talking anywhere near that level. The level we're talking are completely safe. There have been quite a lot of examples of actually where big parts of the country are already fluoridated. Some part of the countries are quite naturally fluoridated. So you've got really good evidence already, the safety of this, which shouldn't be a concern at all. But nevertheless, we do have issues around putting things in our water, and unfortunately, that's having a significant impact on implementation of a program, which can be considered as the single most, from a public health point of view, the single most effective things you can do to reduce tooth decay in children. But it's not just about tooth decay in children, but actually the impact you can have as a result of reducing tooth decay in children goes on to their whole life chances, confidence, mental health, and everything else that follows on from there.
So whose arm needs to be twisted in order to change the policy?
The long drawn out, I mean, this is, if you look at what happened in Northeast, it's ultimately the decision of water companies to actually do this. But actually the consultation process, the legal process, if you look at Northeast, it took decades to get to that place. So there are a number of areas. It's to do with the water supply, it's to do with water companies, it's to do with the bordering between, so for an example, for our, it'll be Thames Valley. But actually, how does it border with London and things like that? So there are lots of things to be taken into consideration. Ultimately, the decision is around water companies, but there are feasibility studies to be done, and so on and so forth. So there's a lot of technical element to this, which I can very happy to sit and discuss with you. But it is something that we must, from a public health point of view, asking a Director of Public Health. It's a no-brainer, but the consultation process and all legal process and everything else makes it extremely difficult to progress these agendas.
How much further can we go on with this? Because it sounds as though it's being done elsewhere in the country. Other people are doing it. Why on earth aren't we doing it here?
Just going to say on stuff, it'd be really helpful if you could provide the committee actually with any of the evidence links, in particular the evidence about what the value would be, what would the country save actually, what would this area save actually, sort of by doing it. And maybe it's a long-term goal, but it's sort of, if it's a no-brainer, you sort of think,
because the committee is looking to write to the government as well to urge support for a local consultation.
I come back to this. So this piece of work is being looked at by UKHSA as we speak, because it's not just an Oxfordshire piece. It goes across a much wider footprint. So it does make sense. If anything, it probably makes sense to look at it from a Thames Valley ICB, Thames Valley HOSC level. So I don't think the evidence is already out there, but it's about actually getting across those barriers and having those discussions of those wider footprint will be the most effective. Thanks.
I think the first step, if you understand the barriers and what the value would be for doing it, you're then on the journey, aren't you, to doing it? So it would be really, really helpful to have that.
Just on that as well, I think if we're going to look at it, it would be very useful to see actually what the costs of doing it are as well, because that will ultimately absolutely impact the water bills that our residents have.
Some of those things. So when I spoke to Northeast, I think it's the regional director who I spoke to, who went through that process over a long period of time. Some of that things are built into the feasibility study. So one of the things that you do is feasibility study when we get this ball rolling. Once you got the consultation, very difficult to predict the costs without actually not starting that process. I'm sounding like I'm giving excuses. Absolutely not. As a Director of Public Health, this is absolutely a fundamental thing that we absolutely want to progress. But I'm thinking in terms of doing this the best way, I think now that we have a Thames Valley level health overview scrutiny committee, having a discussion at that level and engaging stakeholders at that level to get the ball rolling and to get the acceptability into that would be, in my view, the best way to do that, so that you get all stakeholders involved in that space. I'm really happy to support in any way possible in that.
David?
Thank you, Chair. Yes, so I'm looking at the section on contract delivery in the report, pages 7, 8, which states that practices are contractually required to deliver a minimum of 96% of activity each year. If you look at table 2 on page 8, which hopefully sets this out by area, I can see that while Oxford City for 25-26 has got a 97.95% rate there, Oxfordshire as a whole is at 88.62%, i.e. it's below that target. So I'm curious as to what you consider to be the underlying causes of that under delivery in the county, particularly in areas such as Cherwell, which only has 79.5%, and the Vale of Whitehorse, which also is below that figure somewhere, 82.5%.
Thank you. Yes, the dental contract is set out in a strange way in terms of a number of units of dental activity are commissioned, and then the dentists do what they can to deliver against that, which is why we get some variation. There are things that we can now do to sort of rebalance the number of units of dental activity commissioned, and it might be that they are in the wrong place or not. But I think the most important thing, which is where we almost started some of the discussion, is to look at what is the need of the local population, what is required from that for that group. It's something that we do we do keep a view on and do oversee quite closely. It might be down to practices handing in their notice. It might be down to not having a need and having lots of private dentistry. But it is certainly something that we do look at, and we do try and rebalance, because of course we could get to 100% if we just reduce what we were commissioning, but that's not what we want to do. We want to make sure that we are meeting the need and we are replacing any commission service that is passed back to us. So it's certainly something that we need to keep a very clear, and Oxford, and quite why Oxford City is doing well, I can't got an answer for that one either. But I think it's also a bit about it's messaging. How do we get the public to understand when they should be using a dentist, when they should, what oral health promotion is, etc. Thank you.
Barbara.
Just a quick follow-up to that question, because you presented us in the report with a table about the number of UDAs that have been handed back, and then about the additional UDAs that have been commissioned. And again, you sort of see that the new UDAs commissioned is greater than those lost in Buckinghamshire and Berkshire West, whereas you see in Oxfordshire that it is the other way around. And there's a particular issue here in Cherwell. And I'm just wondering why, 22,000 UDAs were handed back in Cherwell, and only 3,995 new ones have been, commissioned. What's the problem in that area?
I think one of the issues is that the further we get away from London, that has the number of dental schools and things like that, the more difficult it is to attract dentists, and that's why the Golden Hellos, which was a national programme which we've continued, we have aimed at those areas where it has been more difficult to get dentists. And I think what we are seeing now, though, is potentially more of the bigger sort of corporate companies come out and spread, but they want to do. They're not interested in doing 10,000, 20,000 UDAs. They want the bigger contract, the bigger contract numbers. I think one of the issues in particularly Cherwell has been the attracting the dentists. One of the other things is when the dental contract was set up way back in 2006. Each dentist gets paid a different amount per UDA. So we've got a huge range of costs per UDA. So some are getting paid £30 per UDA, others are getting paid 35, 36. So it soon gives you a discrepancy of that, and that was all based on historic provision. The new dental contract does help reverse that, although it converts everything into UDAs, but theoretically it does recognise the different weightings of that. I think the access in and around Cherwell will be helped by the new dental contract, but it's definitely something that we do need to monitor and watch. And yeah, and certainly any feedback from Health Watch on difficulties in that area would be very gratefully received.
Melvin?
Thank you. Equally adding to Councillor Hingley's original question on contract delivery, section 3 of the report notes that there are financial recoveries where delivery falls below the 96% level. And the report also outlines an overall underspend of £71,000. So how are recovered funds and underspends being reinvested to improve access within Oxfordshire, please?
Thank you. Yeah, I mean, we are. So I think the dental budget that we have is quite unique in that it is ring fenced for dental use. So where possible, we do look to reinvest that. Some of that reinvestment is going into our children's oral health projects because we're sort of paying additionally for that, and we'll also go into providing services for our vulnerable patients. I think what we also need to remember is that there's the next stage, isn't it? The people who can't be seen by their high street dentists, and making sure that actually our waiting lists in secondary care or for secondary services aren't increasing, and we've done a lot of investment in trying to reduce some of the backlog that is there. But actually, you know, I feel quite lucky in that this money is ring fenced for dentistry, so we do have the opportunities to reinvest, whether that's in health promotion or other things. Last year we used a bit of the funding to do some quality audits about antibiotic use by dentists, because that's an area that's relatively unknown. There's relatively little data. There's relatively little control over what they prescribe, but just so that we could have a view on whether they were prescribing the right lengths of antibiotics, because we clearly antimicrobial resistance is key here. So yes, so that I'm happy to say I can reassure you that the money recovered does get put back into dentistry.
Right, section 3 of the report outlines that the ICB plans to use recurrent rebasing powers from 2026-27. How will rebasing decisions ensure that capacity is redistributed to areas of highest unmet need, rather than simply reducing overall provision?
Thank you, Councillor. Yes, a very good question in terms of what we need to do. I mean, I think it is clear where we have had those dental deserts, particularly in West Oxfordshire, Vale of Whitehorse, and Cherwell, and quite a lot of our work does tend to focus on those areas, and not just going to the bigger practice or those practices that can absorb them, but also interestingly, unlike general practice where you have to live within a boundary, people can travel to other areas for their dental care. Us in Oxford could go to Buxton. Now I'm not advocating that in any way, because actually we want to deliver local services, but it is a careful balance between what we can deliver locally and also where the need is. But in the main, we do look at where we need to deliver, which is why of the 4 new practices, all those 4 new practices have been in Oxfordshire. We haven't commissioned any new practices anywhere else across Bob, as was.
Hey, just picking up on that and sort of the areas that have had the largest sort of historic losses, which was in relation to, I think it was 142,716 units of dental activity lost in Oxfordshire. The historic losses worst in West Oxfordshire and Vale and Cherwell, as you say. But does full recovery, when you had 146,000 commissioned since April 2024, does full recovery of that translate into equivalent patient access locally? I mean, you've talked about the balance, you've just talked about the balance, but I just wonder if you can say anything more.
I think yes. I think it's a good question, and I think where we need to go back to is what is the local need, what is the local population need. We do have a public health dental consultant that works across the Southeast region who helped inform those discussions and those decisions about where the greatest need is. In the main, it's linked to deprivation and inequalities. So that would always be our first focus of where to put additional activity should we need it. But actually, Oxford City is quite well provided for. It's our rural inequalities that we have mainly with dental provision.
So where do you see the sort of integrated care board going with that? Because, you know, across the larger footprint, clearly the traditional multiple indices of deprivation are in the obvious places. And as you say, Oxford City is one of those, but it's actually doing the best by far. So in relation to these dental deserts and access, and that this gap can actually lead to serious physical health issues as well as sort of the dental health, and it's to do with rurality. Sort of where do you see, is there it's something that the Bob Hosk has pushed as well actually for many years, but it's when do we get to a point where there's that's translated into you know, a fair strategy?
Yes, thank you, Chair. And I think this is where neighbourhoods come in. This is so I think this is building up in terms of neighbourhood footprints. What services are there where we need additional services? What is the need of that population? So I think actually the neighbourhood work that is progressing across Oxfordshire really helps that, because it looks at local need and builds from the bottom. And as a commissioner, allows us then to look at that strategic need and things like that, and place those additions where we need to.
So what you're saying is it's the importance of that real place-based collaborative work, essentially, that will get us there. I think. Sorry,
I think
Dan.
it's I think it's like Julie says, what we're trying to do is overlay. So we've got access to really good quality Thames Valley data with insight and things like that that gives us stuff around deprivation. But what we've also got is the community profiles and the rural insights that we have. That so the data hub that we've looked at previously at this committee gives us incredible local insight. And then we overlay that with the community intelligence and things like that that we get from our community groups and groups like we've talked about in terms of My Life, My Choice and some of the organisations that work in the place. So really overlaying all of our information, not relying on one indicator to drive our decisions.
We've got gaps, so I mean, and it's natural because this work's just really started, but we've got 14 areas that have been looked at in rural, but you know, they don't touch on the area that Councillor Crawford was talking about, you know, so it comes back, I think, to that issue around how can local communities be sort of enabled, you know, if they actually fall outside of the work that's being done and the data actually being collected, because that's where the inequalities, you know, live. Anyway, so I think I've got David. Yeah, David next.
Thank you, Chair. Actually, my questions have been covered elsewhere, but I would just take the opportunity to say that I am very definitely not a doctor. I'm definitely just a councillor.
I just wanted to echo what James is saying. It's not just rural areas, there's some urban areas outside of Oxford. And I'm thinking purely of my own division, Banbury, Grimsbury and Castle, which has got horrendous issues regarding dentistry and lack of it. And it's about time somebody from the ICB actually put it into some reports, because I don't see it often enough. In fact, I haven't ever seen it come up in any ICB report or regarding dentistry. And the other question, I've just very quickly, and it came up earlier on. One of the issues I think that people are most anxious about in terms of fluoridation is, and this is to answer freely, is the scare of fluorosis. And I know pretty much that fluorosis, it can only really be something that can only happen if there's a big intake of fluoride in childhood and in the development of the child, perhaps in the womb, through the mother. But is it something that is specific to the individual? I mean, are certain individuals prone to fluorosis, and how will that actually affect, you know, Gen Zers and millennials who have these amazing white teeth? And I can imagine, you know, when you start consulting on this and the scaremongering goes around about possible brown streaks and white spots on their teeth from fluoridation, how's that going to impact on your consultation?
Just to comment on that point, personally, I know the concept about fluorosis, and I know the risk around pregnant women and children, and not just the teeth, but the skeletal system. But these risks are not being founded from the fluoridation process. There's a proper way of doing it. There's a proper way of actually establishing the safety levels. We've got examples up and down the country where this has been done safely for decades. So it's completely unfounded, in my view. Of course, there are fears about all kinds of substances being put into water and things like that. And I think it feels like a natural extension from that. But purely from a water fluoridation point of view, which has been done up and down the country, and looking at the evidences, I'm not aware of any adverse evidences at all from that perspective.
Thank you, that's really helpful. Elizabeth?
Thank you. It's just rather silly comment. I mean, if you can't get the dentist to where the patient, well, the patient to the dentist because of the rurality and that kind of thing, could one think about getting the dentist to the patient? I mean, we have cancer screening buses. People used to go round and have their x-ray for TB and that sort of thing. And you could probably do fairly straightforward dentistry within a van or a bus or something like that. I accept you'd probably be fairly limited, but it might help solve problems of just being seen, really.
Yeah, thank you. Yeah, thank you, Councillor. A couple of years ago, we did run a pilot in a couple of care homes because for that very reason, it's quite difficult to get. Can be quite difficult to get care home patients in, and we sent dentists into into a couple of care homes to look at and do oral health checks, etc. But there was really interesting outcomes because actually, whilst there were caries and things that were identified that could relatively easily be fixed by the dentist, actually it wasn't a priority for the resident. And the resident had other issues that they wanted to sort out first. So I think, yeah, it's not a bad idea, but we need people willing to have the treatment that they need. And in some ways, that there is a bit of concern that we are putting so much emphasis on urgent dental appointments and being able to have that ready access of being able to access your dentist, that actually the more preventative, the more oral health checks, etc., are actually being pushed aside a bit as we move forward. And we just need to make sure that the whole care package, it's not just you've got toothache, you go to the dentist. It's actually that whole oral health and health and well-being bit.
But oral health could so easily be dealt with by people coming to an area rather than them having to get their way when there's no bus or that sort of thing.
Alan?
Thank you. Can I just ask you to expand a little bit on the broader benefits of regular dental checks? I'm particularly interested in the periodontal information associated with cardiovascular disease and the opportunities for regular blood pressure checks. That it's not just about dental infection, it's a broader issue that really does mean that when you start looking at vulnerable groups, you're talking about those in more vulnerable areas, deprivation, prison, care homes, a whole range of issues that isn't always made clear and isn't made very clear in your paper today, that there are real opportunities for improving broader health than just looking at filling another cavity.
Yeah, no, thank you. That's really a really important point, and maybe one that I haven't made as clear as possible. But for example, the example that I just used about going into care homes, thought, well, actually, if you could fix teeth, then people could eat, and then nutrition and things like that would be improved. So that was some of the background. But also using dentists as almost as another healthcare professional to signpost patients to do those blood pressure checks and identify. Although, so yes, it's definitely there's a lot of evidence about actually the benefit of having good oral health and things like that does go by. And our dentists are spotting facial cancer, mouth cancer, and things like that. So those are really important parts of their process.
In identifying vulnerable groups, you need to be a bit more broader in your imagination of what constitutes a vulnerable group. So I think that's what comes very clearly, is that you haven't done that, and that you need to think a bit more imaginatively about health needs and vulnerable groups in the paper.
Thank you.
Slightly related to the point, but I think just to emphasize the point that the interventions that we do to improve oral health are the same interventions to improve well-being of the whole overall population, right? It's the healthy eating, low sugar, low salt, all these things ultimately is good for physical health as well as oral health. So sometimes, we compartmentalize as oral health, but actually ultimately improves your overall well-being as a whole. And I think we just need to be mindful of that. Exactly.
Thank you.
It was good to hear you talking earlier about the work that you're doing in primary schools and nurseries on health promotion, dental health. But we heard earlier from one of the speakers that it's very difficult for families to access dental care, particularly for children. And there were some quite alarming figures that were given at that point. But I was interested to know how the work in primary schools and nurseries can be expanded. So how can that be opened up to more people?
Yes, yeah, thank you. Thank you. And I might come to Ansaf here because there are some roles and responsibilities for local authority in terms of that as well, with things like supervised toothbrushing and bits and pieces. At the moment we're running, this is very much early stages, this is very much pilot. This is very much about, as we commission new dental practices, we need to think about, well, what is the added benefit that they can bring. And actually some of the early learning from those pilots and reaching out into schools are more about parent anxiety about the dental chair rather than the children's anxiety. So there's a whole piece of education, and I think the more that our dentists are sort of seen in the community, seen in schools, seen in nurseries, then actually, and it doesn't have to be dentists, it can be the oral health promotion nurse, which we have commissioned as part of these new practices. So I think it is about learning. We're just about to step it up and out in East Berkshire as now part of our patch, which we hadn't had before. But it's also about targeting where that benefit of that approach is going to give the most reward. So it's certainly something to watch, and maybe next time I come in a year's time again, we will have some good results and show some benefits.
Thank you. Jenny?
Yeah, well, talking of children and starting dentistry, mine started at a school dentist, which was extremely frightening. But at least they went round and at least we were looked after. And my dentist now was in private practice, but she was subsidising it from her own money. So she had to give that up and is now working for an organisation. So I think we've all got stories of that ilk. So, but my question is failure to meet urgent care targets. Vulnerable children deprioritised in favour of cancer patients. What were the key barriers to meeting the urgent care target, and how do these differ across Oxford localities? Section 4.3 of the report outlines that urgent care is largely delivered through general practice rather than out-of-hours provision. Is the current model sustainable, given workforce constraints and competing routine care demand?
Thank you. So yes, there was a few questions in there, wasn't there, relating to urgent access. We do also have out of hours provision through our community dental service, which are provided by Oxford Health Foundation Trust, and many of you will be aware of where our community dental units are. And actually they're quite specialised because they need the quite specialised equipment. When we did commission the urgent dental appointments last year, we did ask for provision on Saturdays and bank holidays, but I think maybe, as we would all expect, most of the demand was for those Monday, Tuesday, Wednesdays. So people who had dental pain over the weekend and needed urgent care. I think the new dental contract is almost making that access to urgent dental in hours in something more accessible. And I think we almost need to run with the new contract, which only started on the 1st of April, to see actually what impact it does have on access on people with urgent dental appointments. So we're probably just a bit early in the rollout to see how that will look, and whether that does impact those people needing weekend appointments or bank holiday appointments. The trouble with those is that patients will often, if they can go to their own dentist or one of the high street dentists, then they'll often get their course of treatment. If you go to an out of hours one, you'll probably get a temporary filling or something like that, which will mean you'll have to go back into the in-hours system anyway. So if we can encourage people to use the in-hours or the longer provision from our high street dentists, then I think that is beneficial for all.
I have noted that the dentist I go to, just out of hours is 111. And that's a big organisation, so it's really quite concerning.
Yes, and 111 will have access to our community dental service. So if you did need, you should hopefully be pushed through to some out of hours provision if it's needed.
Just following up on that, there was a prevention of death report in relation to an ambulance service, the use of the 111, where the coroner found that the NHS 111 was unable to triage in terms of identifying the urgency of the situation. And that was a real barrier to sort of accessing sort of urgent care. It wasn't anything to do with dentistry, but it was to do with NHS 111. And I just wondered if you were aware of that issue, that NHS 111 first going in, and actually how does it enable to actually identify an emergency situation? I don't expect you to have an answer to it.
So yeah, Chair, I don't think I can answer that specific issue, but what I do know is we receive and we interact regularly with the 111 team to understand where our dental calls are coming from and where they are then being directed onto. So we do get some of that information.
Just in relation to 4.4 of the report, there's obviously been financial incentives to actually recruit dentists, and that 17 practices put in, but there's only 3 that have recruited so far, and they've got until March next year. But I wondered if you could sort of comment on where these 17 bids have the 17 bids, or the 3 people recruited, aligned with any of the worst areas in Oxfordshire with the worst losses? That was my first question, and I suppose relating to that, it's sort of, how do you understand the true scale of persistent recruitment challenges in rural areas, including these worst areas in Oxfordshire, West, Vale and Charwell, and how are you evaluating the measures taken to address these recruitment challenges? So it's really just understanding the barriers to recruitment, how difficult they are, and whether any of this incentive is getting people in the right places.
Yes, thank you for that. We have targeted this scheme at the areas that are finding recruitment really difficult.
Yeah.
So and whilst we've got 17 practices signed up, they then need to be able to recruit dentists, which is the bit of the thing that they are struggling with, which is why we've only got 3 on board at this stage. One of the things that the South East region has really struggled with, I think probably one of the main reasons, is we do not have a dental school anywhere in the South East. I think there is talk of one down in Portsmouth, which is another dental dearth area, but again, that might give us more access to some of the new dentists coming out, and I think that's one of the things that we're trying to work with the dental deanery on.
Oh, right, okay, that's really interesting. Catherine?
I got a couple of questions that relate to the trade-off between capacity and complexity. So I'll take the two of them together. How has the ICB evaluated the net impact on overall access versus improved care for high-need patients? And the second part is, how will the ICB ensure adequate provider capacity and specialist capability to meet the needs of groups such as patients with learning disabilities and homeless patients?
Thank you, Councillor. In terms of the high needs patient group, we have very much been able to do that through our flexible commissioning scheme and meeting with the dentists and understanding the patients that they are seeing and where they are doing and what the issues are around that, and you know, we've seen quite good numbers go through our flexible commissioning scheme in the past, but there has still been capacity to do more. We also work with our community dental service, who provide for special care and paediatric patients. You know, those patients who can't be seen in a high street dental chair, who need special time for anxiety and things like that, or for sedation, and we work with them really to understand what the issues are and the people that they are seeing and who best that they can and how best that they can deal with that. If you ask me for numbers, I'd probably find that a bit more difficult, Councillor, but it's certainly something that is very, very high on our agenda in terms of trying to make sure those high needs complex patients can get seen.
Oh, so part of the question was about the homeless. What happens to them?
So for the homeless, the homeless group should be able to access through our vulnerable patient access scheme. But again, it's about the spreading the message that this is where they can get their care from, and making sure that people are pointing them in the right direction. That is a new group that we have added to our vulnerable patient list from the 1st of April this year. And yeah, and I've got a few more groups that have been suggested today.
Right, if the committee's happy, I'm going to run on an extra 5 minutes, which means we should be able to get through. I have three people down. I have David and I have Mark. Oh no, David and Barbara. And all right, and who else?
David, Barbara.
Yeah, David, Barbara, and Alan. Okay, and then we'll finish.
Thank you, Chair. Regarding measuring adequate provider capacity, I mean, what are the difficulties in actually harvesting SNOMED data from primary care, both dentistry and GP practices, to actually measure the need?
I think, yeah. So it's a very good question. And having dealt with both GPs and dentists, it's way easier to get data out of a GP system than it is around out of a dental system. And at the moment, we do not have good access to dental data in the same way that we have access to general practice data. We have access to the number of units of dental activity they have, but in the main, that's about it. And whether the appointment's urgent or non-urgent, but that is about it, which is, yeah, clearly not very good for strategic commissioning going forward, as we need a bigger and better picture.
And it was Barbara and then Alan.
Can you tell us what criteria you're using for selecting vulnerable groups? And with the changes, are there some patients who are no longer considered to be able to sort of access through that criteria?
I think we've always said that our vulnerable group list is growing, and is flexible in its nature to add things in. in terms of in terms of what it was supposed to do, it was supposed to help those patients that had big access, different difficulties, and so the patients that we've sort of lost from our list are, you know, those patients who haven't been to a practice in 2 years, because actually they should be able to now access better, and also people who are relocating in area and haven't been able to sign up. But so those are the two groups that have dropped off, but we are monitoring it, and it's really useful to have suggestions on additional groups that might benefit from that, or who are struggling to access. So yeah, so the group has changed. We added, I think, last year, those patients that needed a dental checkup for a hospital appointment. We've linked teeth and hearts and things like that. So it was really important that we weren't putting barriers in place for those patients to access thing. So yeah, so the vulnerable has a very broadest term possible.
Can I suggest one in terms of what Christy came to the committee about? You weren't here then, Julie, but she actually mentioned epilepsy, which also aligns with learning disability, because they disproportionately break their teeth if they don't have seizure control. Right. Ian?
Just quickly to say, Julie, I asked for some feedback from the LD, because you may not be aware, but we have an LD plan that's been through this committee. And the feedback was very much what we've heard here. There were some issues around geography, around access, but I also have to say there was some really positive feedback in the LD plan. People talking about the care and the quality of the service they received, and very much talking about community dentistry. There is a physical health group as part of the LD plan implementation, and I think it would be helpful if we invited you to come into that group. It's hosted by colleagues at Oxford Health with My Life, My Choice, just to talk about, in more general terms, these issues of access and how we can build on what's good.
Thank you, and very happy.
Thank you. I wonder if you can comment on a recent article in the Health Services Journal, talking about children with complex needs needing general anaesthetics being stood down from their surgery dates in order to allow people with cancer to be treated within target.
Yes, thank you, Councillor, for that question. It's something we are very conscious of, and this is access to theatre space for our complex patients, particularly children who need general anaesthetic to have extractions or other things. One of the we commission our community trust, Oxford Health, to provide that service, but of course they don't have access to theatres, so they need to then they need to subcontract that space to the OUH, and I'm sure you've discussed around this table the sort of the elective care backlog and some of the waiting lists for appointments, and unfortunately we're having to work with both providers to sort of understand, well, where is the prioritization of who should have access to that theatre space. There is really good working between OUH and Oxford Health, and Oxford Health are managing to use some flexible space at the JR, especially over weekends, and can see children through that. But we are also exploring access to other theatre space, such as in our private sector, that could potentially do it. But I think with the children and a vulnerable group, we need to make sure that we are not growing those waiting lists. Currently, I think for Oxfordshire, we have two children waiting over 52 weeks every year for dental theatre space. But it's the group between 18 and 52 weeks that we're conscious we don't want to grow that. We need to keep on top of that. So it's something that we are proactively working on, and is a priority for the ICB to try and work that through.
Thank you very much. And thank you, Julie, for answering all those questions. I really appreciate it. But also having Oxfordshire County Council here today and Dan as well. And it's been really helpful to have hear all those different insights. So can we move to recommendations, please?
Thanks again for attending and answering all the questions and for the report you've submitted. As always, we won't let you go without some recommendations. Number one is for system partners to pursue previously made requests to government by the JHOSC to support a local public consultation or engagement on fluoridating Oxfordshire's water supply. It is recommended that system partners work with any future combined authority at the Thames Valley level to further support this as well. Two, for the Thames Valley ICB to launch a review of the local impacts of changes being made to the dental contract. It is recommended that there is stakeholder involvement in this review, including the JHOSC. Three, for system partners to take collective action to reduce the effects of rural inequalities on poor dental outcomes and on access to NHS dentistry, and to develop data indicators at all district and neighbourhood levels to provide visibility to population need and other rural health inequalities affecting oral health and dentistry access. It's recommended that strong measures are taken, including through public and stakeholder engagements, to tackle broader inequalities around oral health and particularly amongst vulnerable population groups. Four, for NHS dentistry underspends, as was emphasised previously, to be reinvested in the areas of worst dentistry access in Oxfordshire to improve oral health outcomes within the county. Five, for system partners to continue to support oral health promotion using neighbourhood health planning at community level as an opportunity to pursue this. It's recommended that system partners utilise parish and town councils, as well as any grassroots community organisations, to support this work. And finally, as we discussed in the final parts of the session, for the ICB to continue to engage with the dentistry dean to support the case for a local dentistry school to be established urgently, if at all possible. We're pushing our luck there.
Might not be quite in my control, but Barbara.
On number 5, could we ask for schools to be put in there as well as parish councils and town councils? Yeah. Thank you.
So I did say earlier, but on 3, I'll let Omid do that first, and then I'll say on 3. It's all very well and good to talk about rural communities and inequalities, but there are plenty of urban. As I said, in Banbury, we have some very, very deep pockets of deprivation, and they get neglected because Oxford is such a big place, and equally has.
We can use. I think what we were trying to pick up on was that something that Julie said, which is actually that it's well understood what the data indicators are on deprivation, which applies to your area, but the rural ones are undeveloped. So I think that's sort of why, and because of the particular deserts in those rural areas. But I think we could find a bit of wording to.
I've taken it as covered as to tackle broader inequalities as well.
Broader
So, like you
inequalities.
say, the emphasis on rural because of the information that we've heard today in scrutiny and that we know.
Yes. Okay.
I think it's just it's widely understood that we've got these pockets of deprivation, i.e. my own division, Banbury, Grimsby and Castle. We know about this, but they never get mentioned.
I think that's the second time I've heard they never get mentioned, and I've been coming to scrutiny for 3.5 years, and I think we routinely talk about the levels of deprivation. We started with the public health report about 3.5 years ago that identified our 10 specific areas there. So we do talk about it. We are aware of the areas in Banbury, the areas in Oxford and the areas in Abingdon specifically, as well as more and more that we do around rural. So I just think, just for the record, I think it's not particularly accurate to say we don't talk about those areas of deprivation.
In that case, we need to do something about it.
Chair, just really quickly, but also these also are picked up in health and wellbeing boards and health improvement boards and localities around the county as well.
Yeah, I think.
There's
I think
discussions in multiple forums.
There are, but I think anyway, I think Dan has actually said it is covered in that recommendation, actually there, it is. Because it's about all those inequalities, of which the traditional ones come in big time. It's just that the rural ones, haven't been seen. Right, I think we're going to move on to, what should we do?
I think we're going to pause for a break.
Sorry.
if-
Oh my goodness, Veronica.
No, no.
I thought we were going to do it today.
No, we will. We will absolutely do the Health Watch item.
No, I meant now.
It's best to do it justice when everybody's taking a break, so we can listen without being in a rush.
So back at 1:30.
Yeah, I think we'll sort of try and be back in the room by 1:25. Is the committee happy to agree to these recommendations?
Yeah, one.
Thank you.
1:25.
Thanks, Julie and Dan. Thanks so much. Thank you.
Hello, welcome back to this afternoon to Health Scrutiny. And our first substantive item this afternoon is the South Central Ambulance Service CQC improvement journey. The purpose of this item is to receive an update on the CQC improvement journey. The CQC has for a few years ago reported concerns in relation to scars, and the committee previously looked into this in February 2024 and made recommendations. So the purpose of this item is to understand the degree of improvements made by the ambulance service since then in addressing the CQC's concerns, and also be good to assess the degree to which our previously made recommendations have been progressed over that period. So I'm really pleased to welcome to the committee, we've got Paul Jeffries, who's the SCARS Divisional Director for Thames Valley, and we've got Andrew Batty, who's the SCAS Head of Operations in Oxfordshire. So very much welcome to the committee. Thank you for your paper, much appreciated. And I understand that you're happy not to give a presentation and actually to go straight into discussion and questions. Is that right, Paul?
Sorry, Beth, whilst we have a better view of your nameplates, the cameras wouldn't, so thanks.
Yeah, so first of all, thank you for inviting us this afternoon on behalf of Andy and myself and SCAS. We appreciate the opportunity to come and speak with you. As has been outlined, we don't have a presentation because we thought the paper was detailed enough to hopefully answer your questions. What I don't want to do is take your time by telling you the information we've already told you. So we'll hopefully be able to answer and address your concerns. But before we start, I'd like to acknowledge and thank our staff, because it is our staff out there every day that cover our operational footprint as an ambulance service, which is about 2,500 square miles. And they deliver excellence every day. And I think everyone in the room would agree with Andy and myself that our staff delivering the point of care absolutely are at the front edge of healthcare and do the absolute best they can each and every day under very difficult and challenging circumstances. So we need to acknowledge and thank them, as well as all the colleagues in the back office that support us to deliver that service. Thank you.
And I think the committee would like to thank all your staff. And personally, I had a recent experience of a crew coming out to me, and they were so fantastic. They not only correctly diagnosed my problem, but they also managed to give me a treatment there and then, so that I didn't have to go to hospital, although they gave me the choice. But I chose to stay at home, and then I got, everybody else confirmed what the ambulance crew had said. So, and they were the most compassionate, empathetic people. So I would, just from my own personal experience, I'd like to say thank you to the trust. Right, so I'm going to move on to sort of our questions then. And the first one is really that the first part of the report, 2.1, we have the journey from SCAS exiting the recovery support programme in January 2026, and the South East Regional Support Group approved removal of the 2024 undertakings in April 2026. Now, in the same section, you talk about further improvement being required and that the board is clear about that. So I wondered, could you outline to the committee with some specifics, which are the areas that still require improvement and how these are escalated through board governance, and what evidence, have you got some evidence that you could share with us to show that you're really moving beyond regulatory recovery into genuine operational maturity?
Okay, thank you very much. I might need to be reminded of the questions. So in relation to the removal of restrictions back in April this year, that came about through a very close period of national oversight framework, where region work with us on a daily, weekly basis to understand what we're doing. And if you break the ambulance service down into its component parts, it basically comes down to workforce, operational performance and financial position. So those are the three main areas that we are scrutinised against. What we were able to do is we were able to deliver financial break even for the last financial year, and that would be available in our public accounts, which will be published. We also have a recovery action plan in place for our trajectory for our category 2 patients. and we're working towards the category 2 improvements because we need to get back down to 18 minutes by the next financial year, but that's the same for all ambulance services. So on a weekly basis, our executive team monitor the operational performance and service delivery, and I, as a divisional director for Thames Valley, and my colleague in Hampshire, on a daily basis, as part of the senior operations team, we monitor the performance. And what we do is we use our business intelligence team to dig into the data and understand where our operational gaps may sit. Maybe that be around operational cover in terms of ambulance availability. That could also be around, use of community first responders, fire co-responders, and other agencies to support our response. And we've got very strong working relationships with the fire and the military. We've got co-responders. So at an executive level, operational performance is monitored. As part of our financial recovery, we've got our cost improvement programs. So we as an organisation identify how we can make efficiencies within our service to offset our financial funding gap. And we're in the process of finalising that at the moment, and that will be finalised by the end of June. That will be presented to South East Region and HS, and that will be signed off. And then we also monitor our workforce. So we do that for our integrated workforce planning. So that's our planning, predicting, forecasting team, our HR recruitment team, and our operations team. And we look at our operational hours. So the hours required to deliver the service across the footprint. We translate those hours into whole time equivalent in terms of staff numbers. And then the staff numbers are broken down into clinical and non-clinical to enable us to put out an operational ambulance. So part of our assurance framework is at the board, we monitor operational, financial and workforce performance. And that is a business as usual functionality of the organisation. We've made reference to within the paper that it is a difficult financial position the NHS finds itself in. I don't think that's news to anyone. And this year, part of our challenges will relate to our workforce and how we recruit to meet our operational demand, but also manage our budget. I think you wanted to add, Andy?
Which covers it. Okay, thank you. Ron?
Yes. Are there any conflicts on where an issue identified through inspection now in fact they into a change operating program? Change reporting line or change accountability mechanism merely being reported on the action plan?
So I think probably one of the most sort of significant ones we've got at the moment is with our medicine management. So CQC picked up areas of challenge around how we were managing medicines and documentation and all that sort of stuff. And we have gone through significant change organisationally with developing our pharmacy team, building a new site for them to operate in, to be able to better manage the make ready process, as well as making the management of our medicines better. So our crews run with sort of bags with different medicines in, and different bags obviously contain different types, as well as obviously the controlled drugs that we have to carry. So we've gone through an awful lot of work there to try and improve that to ensure that we don't have errors that show up, which obviously have the risk then of patient safety potential. We're just in the process. In fact, we're going live next week in Oxfordshire. It's the start of our rollout of personal issue for morphine management. So we've gone through the process with the Home Office to get licensed, because initially what we used to do is we used to get our supply from hospital supplies and then carry them on vehicles. Through the licensing process, that's had to completely change, and it will be becoming a sort of personal issue. So staff will book it out at the beginning of their shift, carry it with them during the shift, and then obviously book it back in. So improving how the availability and how we manage our medicines, as well as recording and reporting, has been probably one of our major changes.
I think that sounds really good.
Barbara?
So previously, the recommendation from this committee was that internal audit should be adequately resourced and that consideration should be given to bringing it into the organisation. SCAS responded with reference to a board forward planner, governance assurance framework and patient council arrangements. Given that the current report continues to emphasise governance as a key improvement theme, what is the current position on independent assurance, including internal audit capacity, non-executive scrutiny, and how patient and public voice is now influencing board level challenge?
Thank you, Barbara. I suppose an example I would bring around assurance and governance would be, we've introduced what we call the PMAF structure, so Performance Management Accountability Framework. So as a divisional director with the responsibility for Thames Valley, I have Oxfordshire, Buckinghamshire and Berkshire as my 3 sectors. And each sector then has a head of operations, the same as Andy. And underneath Andy sits an operations manager that deals with, broad speaking, the staff element, and then a clinical operations manager that deals with the clinical issues for staff. And part of the performance management accountability framework, I on a monthly basis have to provide upward reporting and assurance to the executive team through a scrutiny panel similar to yourself. So all of the executives sit in front of us and will ask us questions in relation to key matrices. So staff being one around appraisal, completion and personal development plans, around statutory and mandatory training compliance. And part of the framework is around quality indicators. So quality indicators such as hand hygiene audits, vehicle audits for cleanliness, medicines management as examples. So I will then sit in front of the executive team, having worked through the assurance with my team to give me assurance so I can upwardly report the assurance. As a side measure to that, we're in the process of part of our operational restructure, which I believe was mentioned in our previous visit to yourselves, that we were realigning operations. We now have the clinical operations manager as a role that sits within all of our 7 sectors. And that individuals works very closely with our clinical team. So there's shared ownership around the clinical governance and operational governance of our front end delivery of our patient contacts.
Okay. A follow-up. Just a follow-up, yeah. So you didn't say anything about patient or public voice and how that's influencing the board.
So as part of our sort of the board meetings that we have and the public ones, there was an example actually last week where one of my team leaders attended the board with a couple from members of the public that had been involved in an incident where a lady was, I think she was about 7-8 months pregnant when her husband had a cardiac arrest, and she was having to do CPR, and thankfully we arrived and were able to actually successfully resuscitate, which is excellent news. But they now, so that patient voice, that situation, either ones that go excellently like that or ones that don't necessarily go to plan, so that there's an opportunity to understand, learn and gain that experience from those people. So they present areas within the public board, and that again offers that information and input, as well as obviously the non-execs who are coming from various parts of the different organisations bringing in their expertise as well.
Monica, would you?
Yeah, I'd just like to add to that, because I was one of the ones who I think raised it last time, that I mean, in this report it's fantastic to see all this improvement, as you say, but I think the lack of even mention of patient experience within this sort of almost tells something about how are you systematically gathering it. So it's okay, you know, how is your organisation really listening, engaging, bringing that feedback in and having that process where you're actually learning and improving from what you hear from people who are using your services?
So we've got a patient experience team. So anyone who contacts the organisation, whether it be positive reflection or negative feedback, they coordinate all of that information. It is then allocated out to wherever the incident occurred, wherever it needs to happen. Our team leaders, our clinical team educators review that. They discuss with whoever the person making the patient experience concern to us is. That's investigated and then fed back to the individuals. But also the important element there is if we're picking up on any elements of education or any elements where the organisation needs to recognise something isn't quite right, that is coordinated. We've also got the PSURF, so the patient safety process, and they meet daily. They review. So when we get events or incidents come in, they are reviewed daily. And if things are deemed to be more significant, a concern that is raised that could equally be a patient safety event, then processes are put in place to actually identify that, and they could then potentially be reported up to the clinical board that are looking to sort of identify, is there an organisational change that needs to happen? Is it often it's education, often it's potentially individuals and sort of misunderstanding or not having the knowledge. But sometimes there are processes in place that organisationally we need to review to identify that we're delivering the right care.
Just to follow up on that, if you're talking about responding really, whereas this incident's sort of primarily, and I just wonder, because we've been having conversations this morning with other providers who are different in the sense that they're not dealing with that sort of emergency aspect as such. They're dealing with the lead up to it or after or whatever. And I wonder whether that is an important context to appreciate, and sort of whether that. So some of these organisations will say that they've got like trusted partners.
Yep.
Who might be organisations that are actually working on prevention of getting people to go in the ambulance and to sort of end up in A&E, or to make sure that they don't just keep going round and round. And so I just wondered whether there'd been any consideration of whether there might be that more proactive and identification of maybe like the leading causes of people ending up in emergency.
Yeah.
I mean, we had a lady this morning, you won't have heard, but she came and talked about her epilepsy, and she talked about, you know, how much it contributed to emergency. You know. So she's been involved in videos sort of with the OUH or whatever. So I was sort of thinking, yes, so trusted partners, is that an idea or something that you?
I mean, obviously we work very closely within the sort of health unity, certainly within Oxfordshire and wider. So, you know, we are often a part of those discussions. So we have, I mean, we will look at incidents where there could be an adverse incident, even without it being a patient experience. They're looked at daily and identified if there's any learning that needs to come for it, if we've got any duty of candour for sort of informing people if there's something that's not right. We have, so we have I can't remember the name now, but we have a sort of high intensity user type department. So they will look at patients that perhaps for whatever reason are utilising our service significantly. Oh, you need to turn yours off.
Oh, sorry.
So they will look at that, and they will work alongside sort of social care as well as sort of acute colleagues to identify appropriate pathways for those patients, so that they're not always, because the problem is the crew will get to somebody, and often the way they're presenting may result in them end up going to the emergency department, which actually isn't the best for their care or their sort of independence within their condition. So the problem obviously with which is the problem, the challenge for the ambulance service is we get to meet lots of new and interesting people who we've often not met before. So we don't have a baseline to be able to say, well, this person's normal condition is this, therefore this isn't that far out of it, because obviously people tend to call us when it's a crisis. Those people who have significant elements of crisis, often we will be part of any options, and we have systems that we can put information so that if we've got a crew responding to a patient and there's an agreed plan in place, we often will have that on our system, so that will be flagged to the crew so they can understand. We actively encourage non-conveyance for patients, so it's not about just not taking people, it's about finding the best option for people. And we're sort of, you know, we're really blessed in Oxfordshire that actually we're supported by colleagues and partners, and they're really keen for that. So actually often patients and have an option other than ED that we can work
Yeah.
with those partners to do it. So there's lots of different ways that we try and achieve that.
I think that work is fantastic, and it comes through really strongly in the paper, and then it's reflected in OUH work, in terms of the flow through hospital. I was just getting at something a bit different, which was to do with so not the public services and not the actual users, but the organisations who work really closely with users. So it would be like the voluntary sector. I'm thinking that do a lot of work and are relevant to pathways. So it's sort of more like it's just a thought, because it's just something that some of the other, like the county and OUH sort of do some work on. But I know, Veronica, you wanted to sort of come through.
Well, I think it was just to reflect that when we go to, I mean, Ian, you would want to come in here, because the project we did on discharge from hospital, for example, or bringing people into hospital, there's been a huge amount of work, hasn't there, with the ambulance service to stop people having to go to A&E. So rather than just transferring people, they've been encouraging people to stay at home and get that support brought in from that multidisciplinary cross-sector system work that's really showing in Oxfordshire.
I mean, I would say that in Oxfordshire, we are really fortunate for across the whole trust. Oxfordshire has the best non-conveyance rates for the whole trust. And that is predominantly as a result of that partnership working, because we're sort of having people saying, oh, please come to us, unlike other areas where perhaps they're not as developed within those processes yet. So I think, that's one really good development, and that's continuing, and it doesn't stop. It's constantly going, and it's discovering new options for patients.
Yeah, it was just that point, which is sort of about how do we make sure we don't get people in ambulances in the first place. So it's more that point, and whether there's more opportunity for system-wide multi.
So we have got a clinical pathways team, and that team look at alternatives to transportation to ED or non-ED. So, not all of our patients go to the emergency department, some go to other departments within hospitals. But our pathways team, what they do is they look at our call volume and they identify, are there any gaps in our service provision? So do we have a lot of patients in group X that don't need to go to ED but need to be treated? And then they work with partners across the wider system to identify how we can access those pathways. And Andy and the team do a lot of work with the John Radcliffe around when we know that demand is busy, about call before we convey. So we speak to the department about the patient to understand, what the need of that patient is. In terms of the third sector and the voluntary sector, it's not something we actively do on a regular basis, because there are lots of different support groups in the community. But what we do is we look at best practice and the data to help inform our decision making.
Ian, did you want to come in?
Yeah, just quickly. I mean, to endorse everything that's been said, in the Better Care Fund plan for this year, we've increased our investment with Oxford Health around effectively the call to convey. So where people are waiting for a response on 111, then they can be diverted into the community services who can deploy somebody, or when people are on site, we can make a plan to go and see people. I think you were talking about something else though as well in there, because you may remember a couple of years ago, we did a big sort of comms exercise in Oxfordshire around trying to get people to understand our ambition to support them at home rather than taking people into hospital. It's probably worth us thinking about whether, aligned to this different way of working, we keep the messaging out there, because there's something about public expectation. And finally, the bit about working with the voluntary sector. For some people, Andy's been referring to, who make high use of services, what we call high intensity users, there is a thing, for instance, we currently work with the Elmore community for some people who go into ED quite a lot. And there is a bit about how do you make your way to some people whose behaviour change or whose understanding of the options available to them won't be resolved by simply trying to do it within the scope of a call to 111 or 999. So that's an ongoing piece of work, which we could, we were happy to come back here.
I mean, that's really interesting, and like the extensions, what other potential there is sort of around that kind of.
I think the committee made some recommendations around that in the context of the item on the support for people leaving hospital and D2A a couple of years ago. So it'd be useful to share anything around that.
I think the challenge that we do have with sort of engaging with the voluntary organisations in a preemptive thing is often when people are diagnosed with a condition or living with a condition, it's very hard for us to be involved before they start using us, because actually a lot of people will manage their condition without the need of an emergency or an urgent intervention. And it isn't until they start accessing our service that we actually realise that that person has an unmet need, or a need that could be met better than by us. So it's, I mean, we will utilise them for if local teams are doing education within their teams, you know, subject matter experts and things like that. Absolutely, that's fantastic. We try and use that. But for actually preemptively not needing an ambulance until they've needed an ambulance, it's quite hard to understand.
Yeah, I'm sorry, because it's just the opportunity that there is in an ambulance, because you've got that one-to-one person. You've got a unique opportunity which doesn't really exist sort of anywhere else. Now you're under a lot of pressure, but there is an opportunity there where you may find there are things that are not happening in A&E that actually risk assess, provide an easy risk assessment. I mean, I'm talking about something really easy, like you just give people a tool and say, next time, you know, maybe have a look at this, you know, or bring this to show the A&E what your risk is and how they might, so that they don't end up keeping going round into A&E. And I know that's probably happening with, you're doing brilliantly, you know, in terms of that conveyance, but I'm just trying to identify that opportunity, which is so unique to ambulances because of your great work, really, you know, and just whether there's other opportunities.
Crews will often make suggestions to patients around, you know, maybe have a conversation with your GP and maybe can ask for something like that because they're identifying something that might just be missing that just hasn't been picked up by anybody. We do that. Obviously, patients who fall in the community often don't need to go to hospital, but we will do a referral to a falls team who will then follow that up to try and, because obviously once somebody has fallen, their risk of falling again is much greater. And, you know, if they've managed to avoid injuring themselves this time, that's, you know, their opportunities for that run out rapidly, unfortunately. So we do refer to sort of community-based with a view to coming in to identify hazards and risks to avoid future. So that does happen.
Yeah. Thank you very much. Paul?
I've had 2 emergency admissions to hospital this year, and the crews were absolutely superb. However, I think I must have metamorphosed into a grumpy old man like my dad was, because this is where I'm going to actually burst your bubble a little bit, I'm afraid. On the 8th of January, I had a phone call from my doctor to say that I had to go immediately to John Ratcliffe for an operation. I was too poorly to actually drive. I was told to phone the ambulance. I phoned 999, got through to the ambulance service, and I was told, oh, well, it'll be 23 hours to get the ambulance to you. Is it a life and death situation? I said, I don't know. I've just been told by my doctor I've got to go immediately to the John Ratcliffe and to call an ambulance. And they thought I had a strangulated hernia, which is a pretty serious thing anyway. It turned out I've got cancer, and I collapsed in the. I managed to get a friend of mine in the end, who's a taxi driver, had to be a district councillor in Banbury, who drove me to the hospital. And I collapsed in the foyer of the John Ratcliffe. And it turned out my hemoglobin was at 36 when it should be over 140. I don't know whether it's a life and death situation. I shouldn't really be asked that. I was told by my GP to call. I communicated that to the operator, and I didn't get the service that I deserved. And I'm hearing that anecdotally time and time again from residents. And I know you're doing brilliantly on all sorts of things and the management speak sounds fantastic. But if I'm trying to translate that to people that live in the area that I represent, it means absolutely nothing to them. They just want to know that if they or their loved ones need an ambulance and it's an emergency situation, they can get one. Sorry, but
just comment. I think it's obviously about a triage. It's about that issue of identification of emergency or something. I don't know if you can.
Yeah. So we would have our recordings because we do keep all of our recordings, and I can only apologise that you didn't have the service that you would expect of us on that date. To give the background, so our call centres, we've got one based in Bicester and one based in Hampshire down in Otterbourne, and they deal with our call volume. I can't remember what demand felt like on the 8th of January, but it is in winter, so we know that historically our demand does increase during the winter period. That's not an excuse by any stretch of the imagination. But the individual that takes the 999 call is a call taker. So we'll follow a clinical pathways in terms of challenge and response. So ask a question, get a response, leads to the next question. And by that process of a challenge and response, will lead you to a disposition, and that disposition will be a category 1, category 2, category 3, category 4, etc. So category 1 is obviously someone in cardiac arrest, and then our category 2 patients are patients experiencing heart attack, stroke, so there's immediately life-threatening. So without knowing the details, it's okay to call you Paul. I can't comment on your specifics, but there's a question that we would need to follow up. So if we can be provided the information to Andy and myself, we can look into that, because there's something around a healthcare professional pathway where the GP could have spoken to the ambulance service and booked you transportation, so you can get a GP booking. So the GP could phone up and say, I have a patient based in the community, this patient has a high level of acuity, I require them to have a immediate urgent category 2 response, which would prioritize you. Unfortunately, the call taking process doesn't allow for the individual call taker to step out of the pathway, because it needs to triage the volume of calls coming in. Most days we take about 900 to 1,000 category 2 calls a day across the whole of the organisation. Of those, about 55% of them sit within the Thames Valley. So it's quite a large volume.
But if I'm
Paul, I'm sorry, just because we've got another session starting, so I'm just wondering if you've had an offer there to take it.
But this is important, because if what you're saying is true, if somebody's actually saying to the call handler, I've been told by my GP to call you to get me to hospital urgently, that should actually trigger a response, and it didn't.
You've got an offer, Paul, and we don't deal in this committee with resolving individual situations. I know you're not. I know you're trying to highlight something which is really important, and I think you have highlighted something really important, and we've listened to it. But I think you've also got an offer to specifically look into what happened, and so I think I do need to move on. And I think, but I do need to move on to patient safety incident response framework. Barbara.
Hi. In your report, you talk about how you've introduced the patient safety incident response framework into SCAS, and that you've undertaken some staff training around that, and it's being rolled out across the system. And you're now looking at reviewing incidents where things haven't gone as you would have liked them to do. And I'm assuming as a result of that, you've got a culture of learning from your mistakes. I'm interested to know, beyond simply describing the framework, can you instead explain what has changed as a result of the introduction of PSERF? For example, what recurrent risks have you identified? what actions have you followed, and what evidence shows that those actions have actually reduced harm for the patients that you're dealing with? I'd also like to know what what the input of patients is into your PISA framework, and do you use patient safety partners as part of that?
So obviously the education with teams, staff and the team leaders is around looking at the new ways of resolving patient safety incidents and how we do that. So that's been key. As I say, every day there is a review done by the patient safety team to look at incidents from the previous day to see if there are any issues or any harm that is coming to patients. The process is very much more embedded in that there is a much higher what's the word, a much higher sort of awareness and almost like looking for the patient safety elements to ensure that there isn't a patient safety incident. Obviously we've got the patient experience, we've got the daily review. Anything that we use a system called Datix, which is where crews can raise concerns, issues, anything that happens. And what we are seeing across the trust is an increase in those reports, which actually is seen bizarrely as a positive, because people are prepared to make those declarations. And it's also about things like near misses. So whereas historically, I think across a lot of sectors, people wouldn't record that because of fear of what might come if you start reporting that, we're seeing quite a marked increase in our near misses, which is helping that sort of proactive element of looking at where things aren't quite working. Based on the concerns that are picked up, or the patient safety incidents picked up, that will influence the education that we're delivering staff annually, whether or not we need to include something different, something else. The clinical review group who manage oversee the patient safety element, they will issue sort of clinical memos out. So if we've picked up that there is a theme on something that actually needs to change practice or have a greater awareness of, that will be shared across the trust. So it's really important that we identify where things haven't gone to plan, but equally also celebrate where things have. So if things are right, then actually that will also be shared as evidence of good practice. I'll be honest, I can't answer the question about the level of patient involvement. I don't sit within the patient safety team, so I'm not sure as to what level that involvement is, but obviously we will engage with individuals. We obviously have we will have a duty of candor. So if something has happened that hasn't been reported to us by a patient or relative, then we will, based on the level of duty of candor, we will go out to them to have that discussion. So obviously anybody who's involved in one of those from the public, we will actively engage with. And I know historically we have, if somebody is keen and interested to help develop from their experience, we will always try and use that, because a personal experience is always a much better impact on people than not, because obviously all staff go out there to do the best job they can. Sometimes things don't go to plan. It may be because certain symptoms aren't common and aren't necessarily spotted, and those are really good opportunities to actually encourage conversation around, actually consider this for this type of patient group, because actually that's something that isn't common and we're seeing an increase in. So I think, go on, Paul. So additionally to that, we've obviously got a professional standards team which have been introduced now. So as part of the PSERF process, if we identify we need to do a collation of facts to understand what's happened, our professional standards team become involved in that. So a collation of facts would be, as described, the collation of the information to understand what's happened, and that would involve interviewing the staff directly and indirectly involved with the incident. It would also be going out and speaking to the patient, their relatives and individuals. We also have prevention of future deaths. So anything that comes out of the coroner's court, so any PFD that comes out is brought into the organisation. Any learning that comes out of any cases that our legal team support the trust with comes into it and is fed through into the organisation. And also we use the Association of Ambulance Chief Executives and their subgroups, so like directors of operations, and they share learning across the organisation. So anything that comes out on a national level is shared across ambulance services as well.
True. Dave?
Thank you, Chair. Firstly, my family has been a serial user of your service, and I'm very grateful to you and your colleagues, and my thanks. The report talks about the expansion of the safeguarding team. How is SCAS measuring whether this additional safeguarding capacity has improved timeliness, quality of referrals, feedback loops to crews, and ultimately patient protection? And also, you mentioned Datex, a good system. Are you actually seeing results from Datex reports actually being implemented?
So Datex is a good system, and as Andy's alluded to, we've seen an increase in the number of Datexes. So from that point of view, that's a very positive thing for us as an organisation, because it feels our staff, it shows our staff are now empowered to report incidents and concerns. The advantage of the Datex system is it allows the individual to flag whatever the item may be. But as part of that process, then you assign managers, and the managers that are assigned to look into the Datex incidents are able to bring others into it. So in terms of, are we seeing the positive effects of Datex? Absolutely, yes, we are, because the Datex, as Andy's already alluded to, helps to inform how we change practice. The improvement in the safeguarding team numbers has had a positive impact on the organisation. When CQC last came in, we did identify there was a problem with safeguarding referrals. And that was due to a misalignment between paper copies and electronic copies being used. We've now moved to an electronic system, and on our electronic patient record, staff are able to do all referrals at the point of closure of an incident. So if we attend a patient today and we need to do a safeguarding, whether that be an adult or a child or whatever other reason, that's able to be completed. And the system has also got defaults in it that says, you're closing this down, you flag this, do you want to send this now? Are you aware you haven't put this in? So the system is now designed to be intuitive to support the clinician and the individual making the referral to make sure it's timely and appropriate. And as part of the board assurance framework and the integrated performance report that goes to the executive team on a monthly basis, safeguarding referrals and numbers and learning best practices part of that reporting.
And I think we want to look at infection prevention and control as well. Alan.
When we spoke to Oxford OUH in their quality assessment this morning, they identified that their staff were experiencing more violence. The number of staff being attacked had gone up. Is that something that you're experiencing as well? And is there anything you think that JHOSC or other agencies can do to help you?
I wish I could tell you that it wasn't an issue. Sadly, it's been a challenge and has been something that hasn't gone away and has sort of only really continued to get worse nationally as well as locally. We see an increase in patients with challenging behaviour, and it can sometimes be very difficult to identify patients who are aggressive due to their illness, as in sort of infection and things like that, which can cause people to behave differently, or people that are just being aggressive and violent. We have the attack on, the Assault on Emergency Workers Act, so that gives us some. We've given staff body-worn cameras, which they can use, which helps. All of our vehicles carry CCTV equipment inside and outside with a sort of panic button option, which basically captures that recording and is then and is all admissible in court. Obviously, the ideal would be we never have to use it because our staff go out to help people, and nobody, no matter what they do, deserves that sort of abuse, whether it be verbal or physical.
Hot off the press, I was speaking with our risk manager yesterday, and Andy's mentioned the Emergency Services Workers Act, which was an act that brought in by government to stop any violence and or aggression towards emergency workers being acceptable. And there's a lot in there around the impact statements and the individual's voice. But the new Detective Chief Inspector in Thames Valley Police that has OPCAVEL, which is the police's internal process for violence and aggression towards their workforce, has reached out to the ambulance service and wants to engage with ourselves and get us part of the OPCAVEL work within Thames Valley Police. We've seen it successfully roll out in Hampshire Constabulary, and that rolled out about probably 24 months ago now. And like I say, Thames Valley Police want to lean into us quite heavily to get us on board with OPCAVEL and support us. And they are very good, in so much as if we report to the police via their force incident manager, so that's an individual within their control rooms that you're able to speak to from our control rooms that says we've got violence and or aggression towards our staff, the police will do an immediate response to that. And he said we've got body worn cameras and we're in the process of procuring new body worn cameras. We've had these in place now for probably 3.5 to 4 years, and the software is in need of an upgrade and improvement. So we're in that process at the moment, and also our staff have violence and aggression training as part of their annual face-to-face training, and that's around breakaway techniques. That's to enable the individual to remove themselves from potentially violent and or aggressive situations.
Yeah, I mean, it's actually something we're seeing reported across, by all providers. So moving on to workforce very specifically, and I'll just start with recruitment and then I'll go on to more broader sort of support. In section 5 of the report, it says that the rota changes and financial pressures have led to realignment, with basically you having a lot of clinical colleagues, but under what you need for your clinical support colleagues. So can you define what that really means in practice in terms of like operational impacts, and perhaps even relating to the last conversation really about staff and how they deal with abuse or whatever and aggression, but more broadly obviously as well.
Yeah, so for us, clinical staff relate to paramedics who have obviously now undergone, with development over the years, it is now a BSc qualification with a 3-year university degree. Our clinical support staff, we have arranged there, so we have associate ambulance practitioners, which in old money used to be called ambulance technicians. So we've still got some that are ambulance technicians by training, and then they updated the education process and they became associate ambulance practitioners. So we've got that group, and then we've got our emergency care assistants, which I suppose the best alignment you might find with an ECA would be the police PCSO support officer role. So they're not clinicians, but they will work with our clinicians. Yeah. The technicians and associate practitioners can operate independently, but they're not registrants, so they're not registered through the HCPC. But they still have the experience and knowledge to be able to work clinically with support from ECAs. And our emergency care assistants, their role is very much there as a support for the paramedics in providing a full crew to provide that information. So that's sort of how the definition goes between them. Oxfordshire, we've always been quite fortunate of having staff who want to work in Oxfordshire. I mean, who wouldn't? But obviously the advantage we have is we have one of the universities, Oxford Brookes is a university that we've been using for a number of years. So because staff tend to move to where their university is, they conveniently don't want to move away again when they've finished. And if we've got roles and jobs for them, then Oxfordshire is a great place to work. So that's sort of partly why we're very fortunate with our clinical staff numbers and staff numbers generally. Obviously, one of the challenges we have, and I think that's partly being in the southeast, but certainly being in the Thames Valley, is the cost of living and affordability to be able to work within the area. We have an awful lot of our staff who end up sharing sort of accommodation and things with lots of others to make it affordable, but to be able to sort of settle and really sort of grow within the community is really challenging, because obviously we are funded nationally. It's a national pay scale. So what I earn as a paramedic on the road in Oxford will be the same as I would earn as a paramedic on the road in Leeds. And obviously the cost of living is significantly different for both. So keeping staff, retaining that staff can be a challenge. Again, fortunately, we're very lucky. We have a really good sort of sense of community within the organisation around Oxfordshire, which is really positive. But obviously, funding has been a big challenge nationally, and that has had to impact the number of staffs that we have.
Yeah, and again, we see that issue right across the piece, sort of with the public sector. A huge, massive issue.
I'm sorry. I think, excuse me. I think also in relation to your question around why have we got the mismatch between a clinical and a non-clinical workforce in Oxfordshire, the mismatch comes through over the past 18 months, 2 years. We've done a lot of work in upskilling our non-clinical workforce and giving them the opportunity to progress towards registrant status as paramedics. And part of that process is our emergency care assistants being able to upskill to associate practitioners, and our associate practitioners being able to undertake university training to become a paramedic. So we've used our own workforce to recruit to our clinical gaps. And what we've seen in the Oxfordshire area is our clinical vacancies decrease. But what we've had to make the decision is we don't have the ability to backfill for the non-clinical at the moment, because as an organisation, our operational workforce is about 2,500 frontline staff. And what we find in Hampshire is we're over on our establishment. So theoretically, there are more staff in Hampshire. So what we're doing at the moment is we're working through a process where we'll use some of our staff that work in the North Hampshire area to move up into the Thames Valley area to backfill our non-clinical vacancies.
Thank you. In terms of the future pipeline, so all the students that are going through Brookes, I mean, we hear this nationally, don't we, really, sort of about the people going to university and, you know, where they go next. And how are you going to mitigate sort of this longer term risk in relation to pipeline, but also there's a real issue there, isn't there, with graduates and you know, having invested so much in this. What would you say?
I probably can't comment on the graduates coming out of university, because that's their career pathway and progression. So that's no different to whether you choose paramedicine or whether you choose banking, or as Andy said, or law. If you choose banking, you probably wouldn't choose paramedicine, but I don't know. But no, nor could I. But we as an organisation still remain committed to our universities. So from that point of view, we still provide practice placements for those individuals going through university courses, and it shows us as a positive organisation. We are doing a lot of work, and there's a meeting running concurrently this afternoon around our workforce planning, around how we look at our recruitment and future years moving forward and the modelling we need. And what we do is we actively engage with our university and our partners to let them know the position we're in. Because, you know, if you tell the universities our current position, where our position hopes to be within the next 18 months to 2 years, it allows them as a university to adjust their cohort sizes to offset any gaps, but also not put us in the position where a pipeline dries up.
Louise?
Just on that, in section 1 of the report, you mentioned that there are several areas of concern, and the third one was that regulation 18, lack of clinical oversight to ensure staff were supported and had effective development to consistently deliver safe care and treatment. So I just wanted, so given the workforce pressures, recruitment freeze that James just mentioned that you've been talking about there, are you confident that you've got your current clinical oversight arrangements are robust enough to give that support and the possibility of development to staff when you're simultaneously trying to do this realigning of roles, pausing recruitment, changing rotas, etc.?
A really short answer would be yes, but I'll give a context to that. So as I've already spoken to, we've just finished an operational restructure within the service where we've aligned to Thames Valley and Hampshire as the 2 divisions, and within that there's 3 sectors in Thames Valley and 4 in Hampshire. And as part of that, we have put a lot of money and investment into the clinical operations manager. So this is an individual who has the sole responsibilities for the clinical workforce delivery. To supplement the clinical operations manager, we have clinical team educators, and across the organisation, I think, top of my head, was 167 clinical team educators that form part of a management team. So if you think you've got the executive board, executive director of operations, who I report to, then I have my 3 direct reports who have their direct reports. And within each of our sectors, you have anywhere between sort of like 12 to 20 teams. And those teams consist of clinical and non-clinical members of staff, anywhere between sort of like 14 to 22 in number, depending on the geography. And each team has a clinical team educator and a team leader. And the clinical team educator monitors their operational clinical performance. So around key performance indicators such as survivability, reporting on strokes, best care. They do an operational shift with their members of staff. They review their clinical data. They review their patient clinical records. There's a spot check audit. And those clinical team educators report into the clinical operations manager, who reports into Andy's team and ultimately into myself and the board. But concurrently to support that sits the clinical directorate, who supports the clinical operations manager and clinical team educators to identify best practice and learning. And also we work very closely with our education team to make sure that our face-to-face training that every member of operational staff has to do on a yearly basis, that consists of a day in the classroom where you look at resus, safe handling, any changes in practice. And we did a lot of work last year around managing some patients with laryngoscopies, around effective airway management, and that came from a PFD and a patient safety issue. So we are using that to inform our clinical practice. And also we do online e-learning, and that's around Oliver McGowan training. So that's to make sure that people are aware of those individuals that have specialist needs within our communities. I can see Andy is poised to come in.
I was just going to say, we've also, as an organisation, we've now taken on, and we have a chief paramedic officer as well, who is the executive lead for the sort of clinical aspects of operational frontline roles, along with sort of medical director, etc. But his role is around sort of developing that clinical supervision and the clinical support to staff, as well as developing the paramedic role for future needs and requirements, obviously within the financial window, that envelope that we have, but with ideas around how we develop further on skills and things like that. But he's very much leading that work around sort of supervision and practice.
And he's also just appointed a consultant paramedic for the organisation that holds a doctorate in paramedic science. So we'll be doing work to support our workforce and how we introduce clinical supervision wider across the workforce to enhance what we already have in place.
Thank you. So I'm just going to take 2 final questions, which are really, we need to sort of just look at that issue about speaking up culture and psychological safety, which was part of the CQC and the HOS recommendations. So Ron and Gavin, can I take your questions? So Ron first, do you want to go? Oh, Gavin, are you happy to go?
Hi guys.
this is all about speaking up culture and psychological safety. In section 5.0, the report outlines over 800 conversations with staff, 99% of compliance for FTSU e-learning, and a 26% increase in concerns being recorded. The same section then notes an increase in anonymous concerns and says that significant themes remain bullying and harassment, behaviours, psychological and sexual safety. How do you interpret these figures? Is the increase in concerns primarily evidence of a safer speaking up culture, or does it also reflect persistent underlying cultural problems that are not yet being sufficiently resolved?
Yeah, thank you for that. Yes, it's really odd to a certain extent that when you see an increase in something, you're pleased. When it's something like that, obviously we don't want any situation for our staff to feel that way. But as an organisation, we sort of invested a lot in the FTSE, the Freedom to Speak Up process, and really sort of advertising it. We've put in local champions within each of the ambulance stations so that staff don't have to come to a manager, because we don't know that may not be where the problem sits for that individual, or they may not feel comfortable in coming to actually have that conversation. So having champions built within the sort of the workforce, a lot that sort of their peers, they may well be more willing to make this comments, and that's where we're sort of seeing that feedback coming. And I think as well, you know, it's something that we are learning. So freedom to speaking up, it is really difficult for people to do, and it's recognizing, and something the organization is getting a lot better at, is recognizing what that takes and actually thanking people for doing that. But it's not just about speaking, it's about listening up and then following up. And that is where a lot of the work has, you know, we've done a lot to introduce it, but we're also continuing to do the work around the following up and what we're doing with that information, because I think you'll see a spike, and if nothing happens, it just stops. So the fact that we've seen a continued increase is positive, in the fact of people are feeling more comfortable to speak up and actually tell us things that they're concerned about. And it doesn't mean that everything that somebody raises is a concern that is something that somebody's done wrong or something that is bad. Some of it is around things that we just need to do differently, or an awareness, or actually we haven't perhaps explained well enough to somebody or done enough with somebody that their understanding of the situation is enough for them. So I think that you know, it's not all bad news. I think unfortunately with a lot of organisations, the elements around the sort of psychological safety, bullying and harassment is a key element. Some of that is identifying what is bullying and harassment, what is perception, what is intent, what is sometimes a management of a situation that someone may not have taken as a supportive measure, but actually feel that they're. So some of that, as I say, some of that is about explaining that gap. Some of it, unfortunately, is bullying and harassment, because you know there are a lot of human factors, and people sometimes it's the way it comes across, or the way things are done. The sexual safety side of thing is a really difficult one, because obviously it's nobody wants that, and to hear that it is very shocking and difficult. Obviously, as a white male, those elements are not necessarily things that I might see, whereas some of my female colleagues or younger colleagues may potentially have seen or experienced that I may be oblivious to. So it's really hard to have that raised, but I'm really glad that we have done. It's shocking sometimes when you hear things of how people behave, and it's about what we do with that. And it's really important that we enable, you know, we follow up on that, and we go through process. And if somebody has been out of line in what they've done, and what they have done is inappropriate and not acceptable, then we manage that, and we manage it robustly. I think
that's really, thank you so much. I'm just mindful we've got the next item, so that answered it really helpfully.
Can I just
So
add one point to that? We have
Oh.
put an individual in post who leads on sexual safety now for the organisation, and her role is solely to focus on that to make sure our workforce is safe. And we are introducing a new values and behaviours framework on the 22nd of this month, where the organisation from the chief exec and chair down will be out on station introducing our new values and behaviours to our organisation to make sure that we live and breathe these values in everyday conversations and display the person we want to be seen as. Thank you.
thank you very much. And I'm just going, if we can just in 2 minutes do the final question from Councillor Hingley.
It's not your fault, don't worry. Okay, I shall endeavour to ask the question relatively quickly, Chair. So section 6 of your reports looks at handover, and it states in the report that hospital handover is a major national challenge still, but there have been some process improvements here locally. It also goes on to explain that things like daily calls review delays exceeding 45 minutes, that not all delays are classed as true delays, and that joint working has reduced process errors. So the question is then, what, in your view, are the remaining causes of handover delay in Oxfordshire, such as due to hospital capacity or to process or to wider pathway delays after the crews arrive on site? And also, should we be concerned that the trend is going up for the Horton Hospital?
Okay. Different times of the year tend to, as we know, in different weather. We've just had that sort of massive heat wave. That in itself will then have a significant knock-on effect to people's health. So the acuity of patients can often affect the demand, because as acuity goes up, sometimes the options for community alternatives aren't always as relevant or as achievable. So there will be times when, simply because of what's going on in around the county, there will be more patients going into hospital, which obviously creates demand issues. The challenge for all acutes is often the ability to safely and consistently enable patients to leave, to go home to community or to placements, etc. That element is key to the flow, because obviously we keep coming in, and if it's not blocked at the other end, it's not an issue. If it becomes tighter with various reasons at the back end, so to speak, then that can cause delays, and sometimes I've always said that ambulance services have like a tsunami effect. So we sort of appear like 5 or 6 in one go, simply because we've come from different parts of the county at different times. And with drive time, you all arrive at the same time, and obviously the staff taking handover, they can only take so much at any one time. So you'll get episodes throughout the day where it will slow down and then go back up again. It's just, if that demand continues for several hours, that will then create issues with demand within the hospital. We do have what we call release to respond. So if any hospital is having a really challenging time and unable to offload effectively, we will get to 45 minutes and we will transfer the patient onto a hospital trolley, and the crew will leave, and that patient will become the responsibility of the hospital. Simply because that unmet need in the community is sort of a significantly higher risk than the risk that it does present within acute. I'm not overly concerned by the times going up with the Horton. They have consistently been below the national requirements, which is really positive. They have had slight increase. It's not a massive increase compared to a lot of other hospitals, and again, there has been an increase in demand going into the Horton, which has that sort of knock-on effect. So I think I'm hoping and remaining positive that we'll start to see that settle back down. But their increase is only slightly above the national average, whereas virtually every other acute has a much bigger step above the national average. But we agree with our acutes at the beginning of the year a trajectory for them that sits at what is deemed to be a reasonable, achievable time frame. So at least we can monitor to see how they're doing against that.
Thank you. So thank you very much for coming. We've got a number of sort of recommendations which are based on your written report and listening today. So I'll just put these to the committee. Omid, can you run through them?
Thank you for answering all the questions and for the detailed report that you've submitted. There are 4 recommendations. Number 1 is for SCAS and to work with the ICB for this matter to escalate the future pipeline issue with staff and any challenges with non-availability of training placements with any relevant sort of national entities, including potentially the region. 2, for the ambulance service to strengthen opportunities for public and patient involvement. It is recommended that there is co-production as part of shaping and monitoring the Trust's improvement journey. 3, for the Trust to ensure that speaking up, as we were discussing now, is not merely encouraged or measured per se, but to actually evidence that actions are followed up and lessons are learned around the themes emerging through people speaking up. And finally, to ensure that there is continued support for staff well-being, it is recommended that there are clear, measurable and transparent outcomes frameworks to demonstrate success in supporting staff and in tackling any staff burnout.
Thank you very much.
Thank you. Can I just check with the
Committee happy?
committee? Yes.
Earlier on, Chair, sorry. Again, co-production's mentioned there. What's their definition of co-production? Is it the same as yours or mine or somebody else's?
Well, I think that's something that they'll be going away and looking at different definitions of
in the response to the recommendation, it might be useful to sort of give us an understanding of how you would interpret co-production from the Trust's point of view.
Yeah. But also the close working with OCC, I think, where OCC has been working on definitions of co-production.
So very quickly, I would say that a population level service like this is very difficult to do meaningful co-production in the way that we would expect to do it for specific groups like people with learning disabilities and what have you. Nevertheless, it's those groups, particularly as we were talking about earlier, where there's an opportunity to get into conversations which we can facilitate. So people with severe mental illness, high intensity users, learning disabilities, what have you. So I think we can take that away as a sort of further conversation to support.
So we have already been delivering training in respect of learning disabilities with sort of members from specific with specific conditions who facilitate a day's training, supported training, which staff attend, which is really, really good actually. So it's something we are already doing. Yeah.
Yeah. Thank you ever so much. Thank you.
Thank you for your time. Thank you.
Hey. The next final substantive item is Oxfordshire Health Quality Report. And so while everybody's getting settled, the purpose is to examine the Oxford Health Quality Account, and it's crucial to understand the quality improvements, challenges, as well as the priorities of the Trust. Mental health is also a crucial area of focus, particularly due to the full council motion on mental health. So at least the committee knows what its purpose is, and we will be providing feedback. So thank you so much for being so patient there. So appreciate that. And thank you for being here. And it's good to see you all again. So you've been to the committee many times. So welcome to new members of the committee. We've got Rob Bale, Chief Operating Officer of Mental Health and Learning Disability. We've got Emma Lever, who's the Chief Operating Officer of Community Health Services, and we've got Angie Fletcher, who's the Deputy Chief Nurse. So welcome. What would you like to do? We've got your report. Are you happy that we go into questions and discussion, or would you like to say something first?
I think the report speaks for itself.
Yes.
And it's probably more helpful to the committee to go into questions. Yes. And between us, we will answer.
That's lovely. So if I kick off, so in terms of the CQC, you had a good rating back in 2019. In terms of CAMS, you had the CQC come in November 2025, So my question was really about, can you explain what immediate learning and improvement actions were identified internally, sort of from that inspection, and whether those actions relate to Oxfordshire patients or pathways? And then just give the committee a general update on where you are sort of with the CQC since then.
Yeah, so we did have an inspection of our 3 CAMS inpatient units in November 25. The immediate learning that came through were related to areas such as individualised care planning for the young people, things like blanket restrictions, restricted practice, and some medication related improvement work as well. So we had some feedback from the CQC because we didn't have our report issued. Our draft report didn't come to us until March actually of this year, and it's only just been published. So there's been quite some time for us to have the detailed feedback. So we had feedback about the areas of improvement, which we then immediately picked up and reviewed. What we found in terms of the things CQC identified was that it wasn't the improvements per se for things like the restricted practice. CQC felt that we weren't able to evidence that we took a proactive de-escalation approach prior to using a restriction with our young people. So we reviewed that, and actually it wasn't the way we cared for our people, it wasn't the way we delivered de-escalation. We weren't very good at recording it. We recorded when an incident happened, we recorded everything that happened during restriction and post-restriction and debrief, but we didn't record all the really hard work that our staff take to avoid using restrictive practice and all the attempts to de-escalate and manage things in alternative ways. So we put a bit of a programme in about that with our staff to look at actually how we could document that effectively. We improved our incident reporting, so we now have a really structured way of reporting incidents relating to the use of restrictive practice, which includes all the things we do prior to as well as during and after. We improved the way that we structure entries into clinical documentation as well, so that we can now evidence that this is the way we work in Oxfordshire. We work in a least restrictive approach always, and restriction is always, is one of the things that we consider last. So that was one area of that. The care planning, we had some interesting findings around that, because actually our young people did have a lot of individualised care plans. However, they did also have some generic care plans which related to things like orientation to the unit when they might be admitted. So these would be very similar for each person because it would be a similar type of process. So we reviewed that, and actually we viewed that isn't a care plan, that is more of a orientation admission type checklist. So we've removed that from care planning, and the care planning now really does focus on each individual young person. We immediately reviewed every young person's care plan. Some of them had up to 10 individual care plans for one person following that review. We've also produced some care planning guidance for our staff to be really clear, some clarity of how what does good look like, and how do we work alongside our young people to develop the care plans and use the language that our young people use themselves and would identify with. We've also introduced some care plan training, and we've taken a model of train the trainer model so that we can disseminate all of that down into services rather than it being held as a high level training programme across the trust. So we've made several steps in terms of the improvement of care planning. We run an audit to review all of our care plans, not just from a have we got a care plan in place, but to look at a qualitative view and the quality of those care plans. That's our core clinical standards audit, and our compliance with care planning audits now are above 96% in terms of the improvement work that we've made since November. Blanket restrictions I mentioned again. We do have some blanket restrictions, but the improvements that the CQC identified that would be beneficial were that we were able to evidence that we would consider blanket restrictions in the context of each individual's young person's admission to the unit. So we've reviewed our policy, our process, our checklist, how we introduce blanket restrictions, how we communicate those with young people and their families, and how we try and minimise the use where possible. But we do know that there are occasions where we may have to have a blanket rule on a unit, for example, because of some aspect of safety, either of environmental safety or particularly young person's presentational risk at that time. We've had a whole improvement programme really since the visit. It's been held at unit level in terms of they've all had individualised improvement plans. There's weekly oversight meeting by the senior leadership teams of the directorates of those improvement plans. And then there's also, we've stepped it down now to less frequent, but there was a fortnightly oversight meeting led by the chief nurse, again, of the progression and development of those improvement plans. Alongside this, all of this learning has been about our CAMs. We've also shared the learning across other inpatient services because there were commonalities that could be true for other inpatient services for adults or our older adults. So we've made a real conscious effort to, whenever we've learned something, improved it to try and spread and share that learning as well.
Thank you. And Rob?
So just to come in, just think about our CAMS units. You asked about whether it's specifically Oxfordshire. It's not. We have 3 CAMS units. 2 are in Oxfordshire, one's in Swindon, and they actually provide for a much wider geography. You'll be well aware of the pressure on child and adolescent mental health services, and their inpatient services are under even more pressure. And we are probably, we are unique in that one of those units is at what's called an intensive care unit for children and young people. And we're one of, I think I'm right in saying at this moment, 4 in the country or 4 in England. So it's very unusual and it's very different to thinking about an adult mental health intensive care unit. This is for a group of people who are often very emotionally dysregulated and they've experienced much trauma in their lives, and it's how best we manage and support them to learn the skills and to learn to manage their emotions in a less destructive way. And so when Angie was talking about restrictions and the work we do, that's because we spend an awful lot of time working to help people manage their distress before we get to the point of having to do anything that's more intrusive, basically. And that's the sort of work around trying to reduce restrictions, but also trying to work with people. And actually, we do a lot of positive risk taking. So people will escalate with their emotions. They will get to the point where they're beginning to do things which you and I might think, no, we must stop now. But actually you work through, you talk people down, you work to address their distress and help them develop skills. But that for us is an incident. So then we get to report incidents and all the things that you've seen. So it's a complicated place to work.
Yes, and you've been to the committee before talking about the recruitment to that unit and everything. Yes, absolutely. Alan?
Thank you. Hi. Can I ask you about your priorities for next year? And in particular, not surprisingly, the one around, I think the phrase is integrating physical healthcare, establishing an oversight group for integrating physical healthcare across the trust. Is that because you've had so many unexpected deaths from natural causes for mental health inpatients? Is it associated with the fact that your own data unit records things like diabetes very poorly? Less than 5% of inpatients have diabetes recorded. For the rest of the committee, the national figure for the general population is around 8 or 9%. And for people on antipsychotic medication is around 20%. So it's significantly under-recorded. I'm also interested in how you're going to set up this oversight group, what it's going to do and how you know it's going to be effective.
I'll probably tag team this a little with Angie, but let me start. So thank you, Alan. Alan and I have known each other for many years and have a passion for improving mental health care. And what Alan says about the needs of patients with mental health difficulties and their physical health is absolutely right. And you'll be aware that there has been
Some of the ways we measure it and report nationally, it's not just our data that gets reported, so we pull it from a range of different ways, and so it's quite hard to get a clear and coherent picture. And we know that, so we're trying to get a clear and coherent picture of what we specifically are doing for our patient group. You are right, we have a challenge with how diagnosis is recorded and how it transfers across different elements of the system, and there's work to improve that. It's also because we know, you and I've had this conversation probably many times. How do we reduce the unwarranted variation that we see in this group? Patients who have severe and enduring mental illness die sooner than the general population because of their physical health comorbidities. We know we need to focus on that and improve that and get more consistency across the organisation. To be fair, because I think there are different pockets of practice. We have a different way, for instance, to delivering some of the physical health checks in Buckinghamshire to Oxfordshire. The Buckinghamshire system chose differently to the Oxfordshire system. So we need to level all of that up. How are we going to do it? Bringing the hearts and minds of the skilled clinicians we have out there to focus on that as key outcome measures, as identifying making sure that we are improving our data in terms of diagnosis. That this will take a long time, and I'm not going to tell you it's going to be solved rapidly. No, it's going to take time to do that. It's also about making sure we're integrating our physical healthcare teams. We have dedicated physical healthcare teams in our mental health services, if that makes sense to you, to deliver physical healthcare. And that ranges from the teams we have working into our inpatient services, as well as our teams that work with our patients who are in the community. We also have primary care working some of our specific inpatient units, so our older adult units and our forensic units, particularly because of forensic because of the lengths of stay, older adults because of some of the specific complexities. I think then we need to work on how we integrate mental health differently into neighbourhoods, and as the neighbourhoods develop, and think about the cohorts of individuals who've got complex needs who may or may not get those needs fully met and addressed because of some of our disparate systems. So it's how we work into some of the work that's happening in neighbourhoods as well in Oxfordshire. And then of course we have the fact that we run physical health services and mental health services. You've got me and Emma sitting here, and the opportunity to think actually when we've got complexity of I don't know, somebody with mental health difficulties, diabetes, won't engage with the diabetes pathway goes mental health. Emma and I go, yeah, it's mental health. How do we work better together? And do some joining up the pathways. Haven't got all the answers fully sorted out, but that's the work over the next year. I don't know whether Angie or Emma want to add more to that.
No, I don't think so. I think you've covered that. I was going to pick up on the neighbourhood agenda as well, but you've mentioned that. So yeah, we've got a real opportunity here. We just need to harness that.
David?
Thank you, Chair. In part one, your summary of successes, you have renewed your veteran aware status, and thank you for doing that. I'm aware of Operation Courage and Operation Restore. One of the challenges in primary care is just how few of our military veterans the practices are actually aware of. And I'm wondering if there are any plans or programmes in place to actually reach out to military veterans, both in secondary care and in primary care, and what can be done in primary care to actually signpost the services, not only the ones Operation Courage, Operation Restore, but also your own, just to raise awareness, not only of who are military veterans, but to the veterans that these services exist.
I can do, yeah. I'm actually the clinical lead for our veterans service in the trust. So it is an area that we struggle with as well. We've done some work to look at improving our reporting fields and recording fields of veteran status of patients that we meet. And we're working with our staff to build that into part of our first assessment questionnaire so that we can identify veterans and then fulfill our requirements, under Operation Courage and so on. But we do have the same challenge. We're just starting. I've only recently got involved in the work for this work stream. So we're planning a programme this year about reaching it, which will include reaching out with partner organisations and so on, because again we do have that existing challenge of just not knowing who our population are and who we need to reach out to. We're very good at doing it with our staff. We've managed to identify all of the veteran status of our staff, but our patient population is proving far more challenging to identify. But I don't know. You've got any?
I suppose the only other thing to add is thinking how, because we have better shared data across primary and secondary care, if they've got it in primary care, can we see it and use it in secondary care or in social care? And that continues to develop. It's never where it needs to be, but it's developing. And it's how we use that to change our services.
And that's just some work we're planning on doing this coming year to see how we can better exchange data and understand the data. Okay, yeah, do please.
And the systems are evolving all the time, aren't there? So I know that there's discussion about a new system for general practice or whatever, and that being more, having more interoperability. I suppose these are critical things we've been hearing about for years, aren't they? They're very difficult challenges, but they're so important. Just like to take questions on anything more on prone restraint and restrictions, because because a bit of discussion about that already. Barbara?
Yeah, I've got two sort of back-to-back questions, so sort of bear with me. So the first is that reducing restrictive practice section and the account rates the priority on reducing restrictive practice is only partially achieved. Could you give us a little bit more information on what you think you've achieved and what you haven't achieved and what you need to do in the future? So that's question one. That first.
Sorry, I was just trying to write it down so I meant to answer it all. So what have we achieved? So in our priorities that we set for reducing restrictive practice were the part that we achieved was around seclusion. Our priority for the year was to get the measurement of our seclusion right. What we've been able to measure historically is episodes of seclusion. So that's the number of episodes at times a person is secluded. What we haven't been able to measure is how long did that seclusion period last. So actually, we've not been able to know how much we are restricting a person's liberty, because an episode could last 20 minutes, it could last 2 hours, it could last several hours more. So what we really wanted to get right, and we've managed to do that this year and put those metrics in place so that we can measure the actual duration that a person is secluded, and therefore we're restricting their liberty. So that was the achievement part in terms of the restrictive practice, and that now allows us to understand the patterns and trends in terms of the length of seclusion, because ultimately what we'd like is to be able to use it for the least possible amount of time, and we're now able to track really positive work where people are trying to end seclusion quite early and support the person to come back out on the ward. Sometimes it doesn't always work and the person might need to return to seclusion, but we're able to track those sort of themes and trends and then put some improvement work on where we think that might be able to do. The second priority was about the use of prone restraints, and that was the area that we didn't achieve this year. The previous 2 years, we'd had year-on-year sustained improvement for prone restraint. So we did set ourselves quite a narrow target, which we didn't exceed. We fully reviewed all the data. I mean, it wasn't a surprise to us at the end of the year that we didn't achieve it. We monitor our data daily, weekly, monthly, quarterly. So we knew that we weren't going to achieve this, this priority this year. The data tells us that prone restraint is most used to prevent harm to self. So it's used as an intervention when we haven't been able to prevent a person in our care trying to attempt to harm themselves. And secondly, the second use is usually to manage incidents of violence and aggression. And those incidents of violence and aggression, like I heard you speaking with the previous presentation, are mostly incidents directed at staff members where they haven't been able to be managed in any other way also. We've launched a prone restraint task force towards the end of last financial year. We've put some systems in place now that any time a prone restraint is used, we have an incident rapid review. That's overseen by myself and the chief nurse as well. So we look at any other ways we could have managed this situation. What can we learn? How can we think about this patient? Because what we did find is when we reviewed our data, a number of prone restraints related to a small handful of patients. And so it's about how can we really review those patients at an early point and think about, right, these are the risks this patient may pose. This is the behaviour they might display. What can we do? Work with the patient to think about coping strategies, have some positive behaviour support plans in place. So we can really try, we'd like to eliminate the use of prone restraint, although we recognise that there may be occasions where it is the appropriate way to manage a situation, but our ambition is, to reduce it as far as possible. So we put in the task force as well. We use something called a safety pod as well. These are giant bean bags that you can support a person. They're quite comfy, and you can support a person, who might be under restraint to be seated, and try and eliminate the need to use the prone position. We've also got a training programme for our staff about the use of intramuscular medication and injection sites. We found that some staff weren't confident to use injection sites alternative to gluteal muscle, so that we've done some training with staff to upskill people to be confident to use leg, arm, deltoid muscle, so on. So again, that will help us avoid and minimise the use of prone restraint. But it is an area that we are really focused on and we're putting a lot of energy into at the moment. We've recently recruited a reducing restrictive practice clinical lead who started 2 months ago, and again she's doing some really targeted work. When a prone restraint happens, she's going out to the service, she's looking at that with the staff, with the patients, so we can try and understand that a bit further.
It sounds like you're doing a lot, but in the data in the report, it actually shows that the use of prone restraint is used more frequently on 2 of the wards, and also that 89% of the CAMHS prone restraints involve 3 young people. So just interested to know, what you've learned from that and what changes might you've put in place as a result of the fact that it's very, sort of specific, these incidents.
And I think what we've learned from that is a lot of what I've just described to go into the prone restraint task force, is to intervene really early where we might have people who are presenting with quite some challenging situations. In terms of the individuals and your rights, in particular a few individuals in our CAMHS service, we are, as Rob said, there are very few CAMHS services in the country now. So we are seeing a really increased level of complexity and acuity of our young people. I was talking to one of our CAMHS consultants actually, who's worked in that area for many, many years, and he was reflecting on the type of presentation a young person might come with maybe 10 or even 5 years ago compared to the presentations that we get today. Really, really complex, quite often neurodivergent needs as well, that are really presenting in some tricky and challenging ways. And for some of our young people, I think particularly one of the people involved, we are having real challenges finding somewhere to place her. So she's on our unit for a long, long time, really challenging. She hasn't got much hope because there's no end for her at the moment. So that again adds to the complexity and her experience of the service and so on as well. So.
Might be worth noting that if it's a person, I think we're talking about, they're not an Oxfordshire young person, and there is a placement that they're now working towards. That's changed in the last 10 days.
It's been really tricky,
but it's been for a long time.
One, hasn't it?
We've got just over sort of 20 minutes, so I was just going to move on and sort of look at, first of all, sort of patient safety and learning culture and learning from death sort of questions and the suicide prevention work, and then move on to sort of patient co-production and family and care involvement. So I'll kick off with learning from death, which is, first of all, there's a big issue nationally at the moment and also in the Southeast in relation to leader. So it would be really good to sort of hear from you sort of about, you know, what the impact is on the trust sort of and on learning from deaths because of what's happening with the leader program at the moment. So for new members of the committee, the LEADER programme is a national surveillance of deaths and people with learning disability, and it's been going for decades. So I suppose that's the first, yeah, that would be the first question.
So I recognise the challenge that you raise around the LEADER programme. I suppose what I would say is we review all our deaths. So we follow a process, even though the whole wider LEADER system is slightly slowed down. So we are reviewing our deaths. We very actively work to review all of our deaths. Every death is reported, and we go through a process, a very standard process. We then have a whole process of a system where we look at trends and themes in our data to see if there are any particular patterns. Of course, particularly people with a learning disabilities, the complexity of physical health needs. We're working across the whole system. We work closely with partners to look at trends and themes. And what we can see actually in some of our learning from deaths is the age of death is going up. And that's actually good. I know that sounds perverse, but it means we're addressing some of the physical health needs. So,
yes.
So
yes. Yeah, I mean, I know. I mean, nationally, we're sort of at 62 or something for anyone with learning disability.
So we have, there are some improvements.
Yes, there are particular cohorts who die much younger, which is very concerning. And Black and Asian people with learning disability die the youngest at 36, sort of average, which is horrendous nationally. But yeah, so that's good to know you're sort of going up. In terms of question I asked OUH as well, it was when you're looking at the learning from death, what's your relationship with the bereaved family? What is the offer to the bereaved family? So do they get to know everything that you're doing in relation to address that death? Do they, as a legacy to the safety from the person who died? Do you ever involve them in co-production? Which is another big discussion we've had today on the meaning of co-production. But you know, for people who've there's been these worst outcomes, and particularly where there are learnings, that co-production or that work with it has a really therapeutic part to it, as well as the prevention of future death. So I just wondered whether you might comment on that.
I'm assuming we're widening this out from learning disability in your question.
I think, yeah, learning from death across the board would be helpful.
So,
yeah.
So, and Angie will tell me when I get this wrong and correct me because it's very embedded in the process. So yes, we very actively involved the bereaved when there's been a death, particularly in our mental health services, where it's an unexpected death with all the context that may come in a mental health service. And we actively invite families to be part of that process. Not all families will want to be part of that, and that's okay, but the offer remains. When we, depending on the level and type of investigation, we will ask the family to contribute to the terms of reference, to use a slightly overarching phrase, to help contribute to that. We also provide what are called family liaison officers, who will go and who aren't there to be part of the investigation process, but they're there to support a bereaved family, usually when they're bereaved through suspected suicide. So we very actively work to engage families. Is that, have I described that appropriately?
Yeah, I think you have, and I think as well as involving families and carers in our investigation process, I think post-investigation improvement work as well, we've tried to involve families to help us direct some of that, to understand their experience of how we've delivered the services, and also to feed back to families and carers what we have done to try and avoid this reoccurring, or how we've learned and how we've embedded that as well. We also have we employ patient safety partners in our patient safety team. So a lot of organisations chose to take a volunteer approach, but we've actually employed two people who work alongside patient safety colleagues and patients and carers to ensure that their voice is heard and they're actively they're actively involved as much as our members of staff are involved. The families, carers are involved as well.
Okay, thank you. Just before we move on to general safety, we might just want to follow up. Do you have a follow-up question on suicide prevention, David?
Yes, thank you. This is a very sobering topic, and I was saddened to see that in your report there were 57 confirmed or suspected suicides for open discharge patients in the last 12 months. So obviously, the suicide prevention work is paramount, highly important, and it says in here that the Trust is committed to contributing to the Oxfordshire Suicide and Self-Harm Prevention Strategy 2025 to 2030, that it's part of 2 real-time surveillance systems, a national one and one in the Thames Valley, and also continues to embed the staying safe from suicide best practice guidance. So those are good steps. My question is, what specific changes has Oxford Health made in Oxfordshire services as a result of local suicide prevention partnership work, and how are those changes being monitored?
Thank you. I think some of the changes, if I was to start here, we've made in terms of internally, particularly in light of the staying safe from suicide guidance that came out, is to relook at our how we look at risk, and how we ensure we don't stratify risk. We don't look at risk in a low, medium, high, which could mean a low risk for me but a high risk for Rob, or we look at things in a contextual way, in an individualized way, so that we can understand what this might mean for a patient, and we make sure that we describe that really clearly in our risk assessments as well, because where historically where we've had either RAG ratings or low, medium and high, they have been wholly unhelpful in the management of people's risk of harm to self and suicide. So we've changed our training, we've changed all our forms, how we record things. We've changed really the culture around looking at risk and understanding risk rather than assessing it and being formulaic about it, making it much more of a movable dynamic.
Yes.
Yeah. So that's one area that we've definitely progressed on.
And some of it is the ongoing work around how we work with individuals on safety planning and developing a safety plan that's meaningful for them, not just a professional plan. So it's working alongside an individual and often their families where we can do that, and to create a plan that's their plan, that's then available across the system. And again, that shared care, that digital stuff that we're referencing, how do we make that more available so that people know what to do and how to respond? It's how then we embed and think about our urgent care pathway and the accessibility of services. And whilst we may think they're readily accessible, what we know is people tell us it's quite hard to navigate. So it's how do we continuously improve that? And so we have safe havens, for instance, that are on mind for us. And they're not doctors and nurses and what we may bring for people, but they're another way of getting access to help and support. We have our mental health support line through 111. And we also have text messaging services that people can access. This is a range of ways of trying to make things less sort of institutional and less scary to access, and much more friendly. And all of these services are developed and put in place with a level of co-production. So it's developed with people. It's not us thinking it's just a good idea. It's how do we work
We also, work really closely with our public health colleagues in each county that we work with, and because we monitor our incident reporting and data really carefully, if we identify anything that we think might indicate need a further review or maybe representative of something that's happening in the county, then we link in really quickly with public health colleagues to look at that, to understand, is this an emerging theme? Is there something we need to do on a wider level? Is this bigger than Oxford Health, for example? And is there, we've seen in some cases where unfortunately there has been suspected suicide of young people, and we're trying to look to see with public health colleagues about were there any links, is there a social media link in here that we wouldn't be aware of as a provider organisation. So we work really closely to understand the risk for Oxfordshire, I suppose, with our colleagues. So.
Thank you. So I think it would be good to have a conversation about, which we have with OUH as well, sort of around co-production, lived experience, sort of patient voice and quality involvement in that, complaints, that sort of area. So I don't know if anyone wants to kick off with that. Sylvia? And Catherine? Oh, sorry, Councillor. Yes, well, I think Sylvia first. Sylvia.
In listening and responding to the Voice of Patients section, the Trust reports progress on co-production training, staff induction, 2 co-productions of handbooks and inductions for experts by experience, and lived experience project plan approved in February 2026. It also says that in 2026, you will pilot a lived experience reference group with governance and decision-making responsibilities and integrate lived experience into board governance. What powers will these arrangements actually have, and how will success be measured? And how will the Trust ensure that participation is representative of the marginalised communities rather than limited to those already able to engage?
Shall I start? And then Nancy can come in. Really helpful question, particularly the last part that you asked about marginalised communities, because we talk about experts by experience, we employ experts by experience, they're fantastic, but are they representative of all communities? And that is a real challenge for us to make sure we get that right, which is why for us it's not just about those experts by experience. They bring great stuff, but we need to work out how do we hear from other voices. So what do we see in some of the surveys that come through? What do we see in our population health data that tells us about different groups that we're not accessing? And I think the move towards neighbourhoods and understanding in more granular detail the neighbourhoods, the particular populations that we're serving, and actually just seeing, are we actually even seeing in our services? Are they getting a service? And therefore, if they're not getting a service, how do we get in there and hear voices? And hear and understand. So if I'll divert just a little bit. I still work clinically in one of our services and cover traveller communities a little bit, often an unheard voice. And how do we get in there? And how do we get in there very differently? And actually one of our partner organisations, right name here, Restore, may have heard of Restore. They provide a range of support. They're also one of our partners, completely separate to us. They're doing a piece of work through Oxfordshire is a marketplace, which is about understanding this. So through, I think, money through that, they're trying to engage with traveller communities differently so that people can access services who wouldn't normally access services. And I'm trying to work out how we bolt onto that, even though I actually spend quite a lot of time talking to some of our traveller community in my clinical role. But how do we bolt in differently and hear those voices very differently? And I think each area will have different needs, and it's how do we get into all of those areas. So that's some of the work we're doing with our neighbourhood lens on to understand the neighbourhoods really differently. How do we know that co-production makes a difference? I think that's a really big and difficult question to answer. It's very much about what people tell us, what some of our surveys and reports tell us. We have a range of national surveys that we have to that we report on, but whether they're truly representative of the population would be another absolute debate for us. So there's something we have a long track record of variations of co-production. We run, for instance, recovery colleges. Again, I'm referencing Restore, if you know them well. They run our recovery college for us. We actually also run recovery college in our forensic wards, which is very different. So it's a group of people who don't get out, and we take that into that particular. So there's a range of ways that we do all of this area of co-production. We've recently, and probably it's been here, trying to remember, the whole mental health contract for adults in Oxfordshire was redone. I think we signed it last year. And that was co-produced. That was going out to the communities. That was a range of different events with people with lived experience walking alongside a professional team, which included people from Ian's team, people from our teams, going out and getting opinions, getting understanding about how and what services should work. And I've now forgotten the question.
Can I just kind of update? So I think from a board perspective, what we've done is shifted from a patient story to a much longer sort of server user slot there, which is going to be a much more detailed discussion with our service users and our experts by experience. We've had one board meeting so far like that, haven't we? So it is definitely a work in progress, but it's gone from a very managed kind of patient story to a much broader discussion, which is quite exciting to see where that will take us really. And we, you know, we're kind of at the start of that journey, aren't we, organisationally?
The problem is often it's self-selected, isn't it? People come forward who want to talk, but a lot of the people are behind closed doors, don't want to talk.
Absolutely.
They're the ones you need to get to.
Yeah.
So how do you do that?
I think the neighbourhood obviously offers an opportunity. You know, if you're looking at the ecosystem of each place and you're using your community leaders, you know, of which many of us are around the table. Elizabeth.
Thank you. I'll be brief, I hope, because I was actually more or less going to ask a question which I think you've answered about 45% of your relevant QI projects involving lived experience, and I think you've explained why some of them don't involve lived experience. But on the next page, you talk about somewhere about Buckinghamshire having embedded QI, which it sounds as if you don't feel you have. I mean, what is Buckinghamshire doing that we're not doing? And what do you propose to do in the next year to try and embed QI rather more?
Yeah, I can take. So I think we're a really large organisation, as you're aware, and I think we're in different stages of what I would call quality improvement maturity across our different services. It's not to say in Oxfordshire we haven't got a QI culture, and we haven't. We've got really active. What we do in the trust is we operate quality improvement hubs. So each Buckinghamshire has one hub. We have in Oxfordshire, we have a hub for adult and older adult services. We have a hub for CAMS services, QI hub. We have a hub for forensic services, and we have a hub for our community primary dentistry services. So we've got a much more complex and diverse service group for Oxfordshire than we have in Buckinghamshire, and I think we've probably been able to really put some focus into those small services to get their QI, that get more people trained and get the culture more embedded. But Oxfordshire is no way behind. In fact, our primary community dentistry QI maturity is more mature than Buckinghamshire, which doesn't come across in the report. I accept that, and I don't know. I mean, you had an event just...
Yeah, we had an event this week celebrating our QI and our research and our innovation, and I would say it's absolutely embedded in terms of practice, and it's something that brings staff and service users. We had service users there with us, we had carers on the day. It's something that brings joy in a place that is quite often quite tricky. So yeah, we had all kinds of presentations, from podiatry to children's services to district nursing to our community wards, and really linking in with research and that opportunity as well. So I would say completely embedded as normal practice for us.
And that's something we're doing. I've just met with our head of QI this week, actually. We're bringing in a way of reporting to look at the organisation maturity of QI, but then we're also going to put in systems in place to look at each of the areas of directorates maturity as well. And so how we will know you know, how well embedded it is, or if there's some areas that we need to put a bit more focus on and support services to do. And I don't think we've really had that sort of granular view, if you like, of just how is QI operating in our organisation. So I'm really looking forward to that piece of work coming through as a way to measure ourselves for quality improvement.
Thank you. We have got the very important health watch item to do, and we've got the forward plan, and we've got the action tracker. So I'm just going to take the steer of the committee. We have got the opportunity to feedback and to ask further questions sort of following this session, and we'll do that this week. So is the committee content with that we move on to the next item? That has been a really helpful discussion, so thank you so much for coming.
Thank you very much.
And we'll get the feedback to you. Thank you. So Health Watch, Veronica, you have been supremely patient.
Yeah.
So thank you so much.
Thank you. So as usual, the work that we focus on is reflected through the whole agenda, I would have to say. I've fed back written responses to both Oxford OUH and OH and the Sue Ryder quality accounts. We've made interim view visits into the mental health services, inpatient services at Oxford Health, both the Wintle ward and the SS ward. So we saw from patients some of the things that were being talked about here. We have fed into the HOSC deep dive into GP access, and we had a meeting with some of the HOSC members around that, feeding back what we'd heard from 786 people over the year around their GP services and some of the challenges and care they're receiving there. And we're also, just to respond to one question about the military, Oxford Health is part of the civilian military compact and partnership. So there's regular meetings across the county which bring military and counsellors and providers together to discuss all of those sort of veterans issues and highlight the challenges there of families or veterans. So I'll just quickly move on to my report. You're most welcome to please attend our annual review, which is an online event in July. That's open to all, and it's a summary of all the work that we've done in the past year. So it'd be great to have your interest and support at that. So we've published since the last COSC report a number of reports, including the GP one. We've also published some of our community-based research. So interesting, again, the reflection on the Oxford Health discussion about how they reach less heard voices, and particularly those global majority communities. We've worked using community research because, as we know, people don't fill in surveys often from the less heard communities. So we've used community research in reaching members of the older Chinese community in Oxfordshire, very hidden sometimes, and not very vocal community. But we did 20 work with Eric, who is from that community himself, and he interviewed in depth 20 older Chinese people, Cantonese speakers. And we heard particularly strongly, as usual, around the access to interpreting, the understanding and sort of navigating of care, and what the NHS really offers and how to access it. You know, people still saying that they aren't offered interpreters proactively by health services, but also that they are sometimes having to rely on family members, often children, to do the interpreting for them. So there's still, you know, a big room for improvement across interpreting, which we hear from other areas as well. We've also supported a group called Black Women in Maternity. They were funded by Well Together to bring particularly African Caribbean women together in the community in the Lees. They chose particularly to wanted to focus on the maternity issues, building on those other things that we've also supported. A few years ago, we did a film with a community researcher, and there has been a lot of positive progress from OUH, in particular with the Early Lives project and working very closely with the community there. But this is an additional voice into that sort of supplements it. And those women work with Healthwatch Oxfordshire to do that sort of research process and bring those voices to the fore. So the next step of that is that they are holding an event bringing together all of those voices with the Health Service, ICB and OUH, I think, in July. So we're continuing to support that process. They also fed into the National Inquiry, the AMOS report. We heard from, I think they highlighted some of the common themes around maternity that we're hearing widely. So Healthwatch Oxfordshire is also doing outreach just to hear a little bit more about maternity. In practice, we haven't really done that because there is a lot of pressure on that service, but also we haven't usually gone on to the territory that's the Maternity Neonatal Voices Partnership, but we are doing that now. So we're doing proactive outreach across the county to family toddler groups and that sort of thing, just to get very, using our feedback forms just to hear what's good, what's not working so well. So we'll feed that in later on to the service. We're really proud to have modelled co-production, I would say, with this development of a community research how-to guide. That was through a series of 4 workshops with grassroots communities from African Caribbean, Sudanese, Nepali, Oxfordshire Community Neighbourhood Plan Group, the Lived Experience Advisory Forum, Oxford Community Action, and many others took part in really vibrant workshops over the winter, where we talked about what community research was, and we developed and built on a really visual, practical, community-led how-to guide for people who are interested in voicing their stories through using community research. And unlike other how-to guides that are out there, which are mainly aimed at academics on how to work with communities, this is very much about communities reflecting and working, with support, but from their own issues. And we've fed, that's been part of feeding into the community research network in Oxfordshire as well. And our next steps with that are to develop some really hands-on training that can build that out. So enter and view visits continue. We've just produced reports on Catherine House Hospice and, as I said, Ashurst Mental Health Centre. I'm visiting Abingdon MIU on Tuesday for another enter and view there. We've spoken in the first quarter, January to March, over 500 people just as we're out and about. That's across county visiting groups and events. I was at the Eid Festival last weekend. I'm going to the City of Sanctuary event on Saturday. So we're around and about quite a lot, talking to people and listening. And our webinars, as I've said, we helped Oxford Health reach people to feed into their 5-year, 6-year strategy with voices from across the county, particularly patient groups. Our Marmot event, Ian came to that. It was on Monday. It was going to be a big community event. It was a big community event. We had 87 people booked. We had everyone there. It was really exciting just to see the energy in the room. So that was about combining community voices, really grassroots again, and decision makers. But lo and behold, the heavens opened within 10 minutes of arriving, 86 people, having planned this for months. We were at Rose Hill Community Centre and it leaked all over the place. So they pulled the plug on us and we had to send everybody home. So, but we're really thankful that ANSAF rose to the occasion, ANSAF ASA, and we are going to incorporate that into his public health annual report showcase event on the 10th of July. So, you know, everything has a silver lining, as we know. Forthcoming reports, end of life care we've talked about before, that's still in the pipeline. And then we've just finished, as of tomorrow, we'll be submitting our draft report on rural outreach, where we've reached over 800, 700 or so people across these 14 rural settlements, a mixture of outreach, on the ground, focus groups and surveys. So that feeds into Marmot and then it gets taken, it'll come to Marmot September, I think it comes from Public Health, that report. And then just finally, quickly to pick up on, I didn't write much about the things we're picking up on. I think they're partly in the reports we've written, not hearing so much from dentistry, as I've said. We're continuing to hear about GP access, but you know, that's a sort of ongoing. But I think we are hearing a little bit more about people across services trying to make complaints and comments and feedback, often not getting responded to in timeframes that are appropriate, but also not getting responded to at all. I have raised this with the ICB, who've talked a lot about pressures of AI-driven complaints, which are putting additional pressures on teams. But I would say it feels a bit like there is an under-resourcing of manning or ladying, whatever we call it, this. So yeah, I think it's just one to watch as we go forward. Future of health, what we've talked about. So thank you.
Thank you. Well, it's a vast amount of work, Veronica. And it was good to see that you got some social media out about the Marmot event, even if it was flooded. So, and you've got something coming as a silver lining to that.
And it's.
And the research tool, I mean, that is so interesting.
Just to add to that, it's available for anyone, this guide. It can be put on anybody's website, so it could be on you know, county council, district council, town council, parish council websites. You know, anyone can use it, or we can provide the stuff for you to put it on your case. So the Neighbourhood Plan Alliance, for example, are really interested in you know, making sure that it's embedded within the neighbourhood planning process across the county. So please do look at it, and it's a practical tool and it can be used in all sorts of ways. And I think with neighbourhood health as well, it's very relevant.
I think if I could just come in there, sorry, in terms of the amount of documentation or paperwork that's involved, there might be a possibility to publish that as part of the Health Watch Oxfordshire update in the next Health and Wellbeing Board meeting on the 9th of July.
What do you mean, publish?
Yes.
What, the how-to guide?
Well, everything that you've referred to.
On the 9th of July. What's the 9th of July?
The Health and Wellbeing Board meeting.
The Health and Wellbeing Board.
Yeah.
Veronica's probably trying to think what she's got on the 9th of July.
Depending on we can take this discussion offline.
I think it's incredibly important because there's a huge debate, obviously, about neighbourhood, and a lot of that is around data and how you achieve impact, and how it's not an academic model. It's about how you translate, how you work with communities, not So a resource like that is clearly sort of bang on, really. So Louise.
Yeah, just Well, one kind of a comment really, but as always, by digging into little herd communities, you find something that's actually fairly universally applicable. And I'm thinking particularly of the Cantonese speakers that you spoke to, who really struggle to understand some of the things, terms that they're hearing in their GPs. I have a PhD in cell physiology. I quite often struggle to understand some of the things my GP is telling me. So, you know, that I don't know. I mean, some doctors are very good at putting it in layman's terms, but some are not. So I think that's a really good flag to send to GPs to think about how you word things for everybody. But I can see, yeah, particularly for Cantonese speakers. So that was one comment. And the second thing, you mentioned AI-generated complaints. What is an AI-generated complaint?
Well, I'm not receiving the complaints because in the health service, but I have heard from OUH and the ICB that patients are increasingly going on AI to sort of help them write their complaints and frame them. So they're coming in very much more legalistic and technical terms, very complex, not necessarily totally well informed. And then it means that there's a additional, you know, much more onerous response needed in working it through. So I think there is an area for, you know, really supporting people to understand how to make a complaint, where to make a complaint, how to write a complaint and that sort of thing, because it's sort of additional pressure on top of what is already increasing complaints.
It's also the same with freedom of information requests. So it's the same things happening with AI. Yeah. Barbara.
No, I was just going to say that, you know, a complaint letter that might have taken you as an individual, you know, several hours, or if not days to create, can be created in 2 or 3 minutes, as long as you give the right instruction to AI. It churns it out and then off it goes. And certainly from our experience at OUH, there is definitely a huge increase in the amount of workload as a result of the generation of more people feel empowered to make complaints because they've got a tool that can help them, whereas previously they might have found it really difficult to actually put down their complaint in writing, and so now it's very easy.
But I think we need to be careful not to see more complaints as a bad thing. It isn't necessarily a bad thing, you know, in terms of it needs to be heard as well, doesn't it?
Yeah.
Well, I think actually, Veronica, you're also demonstrating that it's really important to have an organisation that is there for people to even talk about their experience of making complaints. You know, you've talked about how people are probably finding it more difficult at the moment and with deadlines and stuff like that. So I do wonder, I wonder if anyone's got any more questions of Healthwatch, but what you're talking about does actually link in with our future work programme for September. And so are you happy to, is everybody happy to move on to that? So what we've got is the proposed at the moment that we have independent patient voice update, and the exact purpose and scope of this, I'd like to make a suggestion actually that we use that to actually widen it and to include complaints and include co-production, so that we're looking at the organisation, but we're also looking at the ways in which voice is actually demonstrated, which can be through going to Healthwatch or like doing a survey. It may be doing a story, it may be complaining, it may be, so there's lots of different ways in which voice comes through, and I think that might actually be a really interesting item, where we can start digging in as well to like how are organisation managing their complaints, and have they got the resources to do it, and also how do they get people moving from that territory into the learning territory where actually, you know, co-production becomes possible, and where you actually
I think it's probably worth something we can discuss as part of the Healthwatch update item.
Oh, right, okay.
As opposed to the independent patient voice update, which is an update on the work from the Health and Wellbeing Board to explore patient voice.
I know it is, but I just thought if we have a whole hour on it, whether we could also not do complaints as well.
I suppose the theme of complaints could be addressed in a separate context, perhaps in the context of the Health Watch item. Veronica, is that something you can advise on?
I mean, it's not really for me to make an opinion, but my opinion would be, I think you're talking about looking at the report, are you, that's come from?
Yes, it's
Health
got
and
to be the
Wellbeing
report, yes.
So
yes.
that's perhaps what you should be talking about. I don't know.
Well, we definitely want to talk about that.
Yeah.
I suppose I'm
I
just
think
picking up
the
on what
danger-
you've
danger
identified.
being if we start talking about what co-production is, which is, as we've heard today, lots of different views, we might lose the critical decision-making thing, which is probably about independent voice at this stage.
Yeah.
But I'm Health Watch Oxfordshire, so I would say that.
Okay, well look, we've got that there as proposed in the papers, and then we've got the Horton General Hospital update. So this is also here because it's really important. We've heard from a member of the public today who was representing Keeper General Horton General.
Yes, I was going to suggest that, and epilepsy, that we don't lose that.
Right, okay. Well, look.
So that was what I was
Okay, so what we could do is have a little list
I
here.
have been quiet for half an hour, so I had to.
No, absolutely. So at the moment, we've got independent patient voice update, Horton General Hospital update, and the system pressures update, which at the moment are suggested for September.
System
We've
pressures
also
being
got.
emergency care pressures primarily, which we ordinarily look at.
So we've also got epilepsy mentioned. We've got something around complaints and also co-production. There's something about that we may not capture in September, which possibly we might want to sort of look at. What other things? What other, Barbara?
We talked sort of previously about something about district nurses. I mean, the Nuffield Trust has just produced a report that basically, saying how district nurse services are under a huge pressure. A lot of people are leaving because of the workload, and also we've talked about how the district nurse service should be integral in neighbourhoods and the need for care in the community when the service is under such pressure. So I thought it would be interesting to tie that in with neighbourhoods.
Yeah. Anything else? So we've got a program like to take us to, we want to have topics to take us through to April. We need to be at least 2 ahead because we need to commission the November one before we come back in September. So we can create a list. But I'm suggesting today we actually decide what we want to do for September and also what we want to commission for November.
I think if members are happy for September, we could have the independent patient voice update, and we can also consider whether we can look at the complaints aspect or some of the findings that Health Watch found in a slightly more extended Health Watch item.
Section. Yeah.
And then we'll have the Horton General Hospital update and the system pressures. That will pretty much cover September. And as for November, and in light of what we've been hearing, and in light of recent developments, perhaps a neighbourhood health plan update would be in order, alongside an update on medications and medicines management. The committee did look at this approximately 2 years ago and committed to looking at it again to receive an update. And a lot has occurred in that area. And also an epilepsy services update to follow up on recommendations that the committee made 2 years ago, again, in relation to epilepsy and medicine safety to do with valve rate policy and staffing and resource at OUH for epilepsy services as well.
And if we were
that would pretty much cover September and November.
So what with district nursing, would we look to bring that in, have everybody involved in neighbourhood, including district nursing, or would we maybe think also having as a separate item on district nursing?
If the committee's happy to delegate to Jane and I to take this up the line and have a conversation with relevant officers as well and seek advice on whether district nursing is something to look at in the context of the neighbourhood health plan, because I know there is some correlation, or whether it's something that we can do justice to in a standalone item.
Previously, we had, health report on health visiting services,
Yeah.
but I noticed I didn't see anything in the OH report about district nurses. I don't know if anybody else did.
I think what you said, I think the district nursing is, I mean, it's so important in neighbourhood, isn't it? I wonder if they're part of what we might do with neighbourhood in that November, but it might be actually, it needs to have its own separate thing as well. Don't know. But Paul?
I think co-production was actually covered by the People, Health Overview and Scrutiny Committee last year or whatever. I think you were part of that, Jenny. And the Horton will take a huge amount of time. We're trying to cram too much into a programme, and we'll be in the same position as we always are. We haven't got enough time to discuss this. We've got to move on to the next one. And I think we'd be better off actually reducing the amount of things that we're trying to look at.
Yeah, I think
I'm afraid it's unusual today, Paul, that we had 4. We normally just have 3. We normally finish at 2.
Yeah, no, but you're talking about all sorts of things and adding them in. And
no, it's just 3 things for September and then 3 things for November.
Sure, I know, but I think there are plenty of important things, and I'm sorry, but the patient voice, we hear from Health Watch each time. I think we'd be better off looking at things like district nursing as a discrete item and other things. I mean, there's plenty of things that we could be doing that are of vital importance, and I'm sorry, but we keep coming back to the patient voice.
Barbara?
I thought the item on patient voice was because we were looking at the health and wellbeing task and finish group report, and that was what was coming to us for scrutiny. So it's a specific piece of work.
Yeah,
it's not a general thing.
In response to recommendations from this committee.
Yeah.
And from a full council motion about exploring what a future independent voice could look like if Health Watch was abolished.
Shelley?
Yeah. What seems to have slipped off altogether, or maybe they've stopped doing it now, was actually the hospitals coming out to people in their own homes, home nursing, for doing various things. It's not quite district nursing, but it actually came from the hospital. They used to, nurses or practitioners from the hospital used to come out to you, and I haven't heard. I mean, I had it myself for a little while when I needed them to come out and sort me out, and I haven't heard it again, so I don't know if that's still going on.
Well, maybe if there's a district nursing item.
Did we find out? Maybe we could delve into that.
It could be called community nursing, couldn't it? So it could be district.
Yeah.
Also
So instead of the patient going to the hospital actually came out into the people's homes.
Okay. I'm just going to.
Could I just come in, because that is absolutely the neighbourhood agenda in the broader sense.
Yeah.
It is about taking, as far as possible, supporting people to be treated in their own homes and close to home. I would suggest that, I mean, probably has a conversation with somebody like Sue Butt and Michelle Brennan about if there was a report on neighbourhoods and the committee were interested in what does this mean for community nursing, what does this mean for district nursing, how well they could be incorporated. You might then want to just think about what you're asking, because a sort of proposal for how they might work together may not tell you too much about how they're working now. So there's a slight, are you interested in district nursing in the here and now? Or are you interested in the plan for district nursing going forward? Sounds to me you're probably interested in both, but that would need to be teased out a bit to be fair to whoever's going to talk.
Yeah. I think all we need to do today, because in the September meeting we can revisit the plan, is decide the items for September and for November. So at the moment we've got a proposal, that we have the independent patient voice update, which is a very specific proposal, which is coming for continuation of local independent voice. We've got the Horton General Hospital update, and I think I would be saying in relation to commissioning that actually we will want to meet with the Keep Horton General group as well as with OUH in relation to the commissioning of that item, and we have the system pressures which we always have to have. I mean, so that we know how we are sort of heading into the winter, and then the November neighbourhood, medicines, and epilepsy. Elizabeth, and then
may sound rather trivial, and maybe it's still too much in private practice, but perhaps in medicines we could include looking at the potential impact of all these new anti-obesity drugs, which do seem to be sort of changing people's environments, changing their shape quite considerably.
Diet drug.
I mean, I don't know, it may be too much just for people who can afford private practice that they get the drug.
Well, actually, if we were doing the medicines item and we had the community pharmacy people back like we had last time, they have actually got a campaign at the moment, which is actually around pharmacy being involved, really managing and supporting people sort of in relation to those programs. So the medicines item it's such an important item actually, and there's so much under it that it could come in there. But Alan?
So thank you. Maybe I don't understand how the agenda setting works, but where do the primary care task and finish group come in?
Right, so the primary care task and finish group, it will come back in September. And we will have a discussion on it because it will be recommendations from the working group to this committee. Is that helpful? Yeah, thanks. And are you happy with medicines, Alan? Yeah. All right, thank you. All right.
Is the committee happy though to delegate to the chair and myself to do some minor tweaks if need be? And also there's the actions and recommendations tracker. Is the committee happy to note that? Yes. Thank you.
Great, thank you so much everybody. Long day. It's normally not till 4, but we have actually finished on time.